welcome our guest speaker, professors, seniors, and my dear friends to day 2 of MTIM 2020, a 3-day international webinar organized by the Department of Microbiology, St. Xavier's College, Autonomous, Kolkata.
Kritika.
2020, a 3-day international webinar organized by the Department of Microbiology, St.
Kritika, you may continue. You're on mute. Please continue.
Thank you.
Yes.
Today is an eventful day when we will get the opportunity to hear an enriching lecture from our guest speaker, Dr. Nandini Haldar, see some interesting presentations made by scholars and students, and watch a vibrant cultural program. So before much, I request Dr. Arup Kumar Mitro, Associate Professor and Convener MTIM, St. Xavier's College, Kolkata, to kindly hand over the mic and introduce the guest speaker. Thank you, sir.
Thank you, Kritika. It's really my privilege to introduce Dr. Nandini Haldar. And while going through her biodata, I was really very proud because I just immediately thought of those days about 25 years back, a student of high secondary, and where you are now. It's a matter of pride, and a pride for a teacher who is introducing a worthy student. So Dr. Nandini Haldar, she completed her MBBS from University of North Bengal, and she was the topper, and she was awarded with gold medal from there. And subsequently, she practiced for some time, did her house staffship, and also worked in other hospitals. And then she went to UK and completed her post-graduation in molecular genetics from University of Leicester. And then subsequently in UK, she had an illustrious career. She did her DRCOG and MRCOG from London. And I just could see that she has a unique combination of teaching, research, administration, and also definitely a doctor. Primarily, she is a doctor. So this unique combination, when you are having, I could very well imagine how busy you are. And in spite of that busy schedule, you are here to share your experience with us. And she also, as I was telling, she widely practiced in different hospitals in India and in UK. And she is a specialist in gynecology, obstetrics, and also different other complications associated with the pregnancy. And she has also taught in different university. I could see she taught in Swansea University in Wales and had research experience, widely publishing papers in different journals of national and international repute. She did so many technical diploma in different laboratory skill, and she is going around in the world presenting her research paper and giving lectures and delivering posters. And I could see on a regular basis, she has been publishing her papers, and these papers are of immense value because papers normally represent not only scientific finding here, but also clinical finding and solution. So I could gather from the papers that she has written that she has actually done a lot of research on different complications and cases during pregnancy. And most importantly, she is also a learner. I really appreciate that. All the time, whenever you are in clinic or you are administrating the institution, you don't have any time to learn. But I honestly find that she has done a lot of diploma and she has done a lot of refresher courses to revitalize her knowledge. So this unique combination makes Nandini different from normal doctors who are only practicing in clinics. So with this very words, I don't know whether I did justice to your illustrious biodata, but definitely I just tried to do justice. So with these words, I pass it on to Dr. Nandini Haldar, and I believe her lecture will be taking us to a new dimension, particularly with respect to COVID complications along with pregnancy. And of course, in UK backdrop, which also suffered to a great extent over the past 7-8 months. So over to Dr. Haldar. Thank you very much.
Hello, a very warm welcome everyone to your second day of the webinar. I hope I'm clearly audible and visible. Somebody let me know, please.
Yes, ma'am, you are.
Thank you. Is the screen visible now?
Yes, ma'am.
Thank you so much. Thanks a lot, Arubda, Professor A.K. Mitra. And I was deeply touched, emotional from the time you have invited me to this platform to this day. And only a guru can so lovingly introduce the student in front of the audience. So it's a big honor and privilege on my part. So thank you for this invite. And it's only the beauty of a webinar that you can connect to so many people from around the globe. So here we go. I have been into women's health for a long time, and this is a topic which is very close to my heart and a sore topic for all. So together we can try and understand a few facets clinically, and we still know very little about it. So the job of the webinar is to understand a bit better together and try and tap on those dark areas that needs more understanding in future. Good evening, good afternoon to everybody from different parts of the world. So for in India, my heartfelt love and regards to Reverend Father Dominic, and to all the faculty members who are there at the moment. Okay, let's see if the screen. Okay, so this is my second home. Wales is the country where I am in for the last 10 years. And that's my base hospital, Glanwilly Hospital, which is part of the 3 hospitals we have at Hywelda Health Board. Wales is part of United Kingdom, which comprises of 4 countries, England, Scotland, Wales, and Northern Ireland. And it's pristine natural beauty. You have outstanding beaches, the national park, the Snowdonia National Park, numerous forts and castles. You can't imagine Wales and Scotland without the forts and castles, and that's the Cardiff Castle you have. And the trails, the waterfall trails, and in the middle, you have the complete mood uplifter, the host of golden daffodils in the name of Sir William Wordsworth. That's the national flower of Wales, and you'll see the roadsides brightening up every May with those flowers. And at the bottom I've kept, that's like a Wales Jorashakor Thakurbari. That's national poet of Wales, Sir Dylan Thomas's tranquil riverside boathouse in Lugan, where he used to go there to recuperate from the life stresses and come up with some creations. So I have a few declarations to make at the start. I'm not a microbiologist, but I was quite keen to the subject during my undergraduate MBBS days. But today, if any of my patient is not responding to the therapy that we are giving and is going downhill, phone a friend will be my microbiology colleague first to think about the alternative therapies. Secondly, I didn't have the good fortune of studying at the St. Xavier's College Microbiology Unit, and I can see What an amazing job they'll have done over the years. The facts are very volatile and they are bound to change on a day-to-day basis in view of the new research data that's going to come. I'm not aware of any conflict of interest at the moment at individual or institutional level. And whatever I say today does not have any money backup or sponsorship from any company or individual. And that picture is from last year when I went to give a talk at the World Congress of Perinatal Medicine in Istanbul, Turkey. And it was a talk on a newborn with craniofacial abnormality. It was a joint project with me in the Obs and Gynae department in Wales, and in collaboration with the work done by my husband, who is based in Kolkata, India. He's into head and neck surgery. So that work got accepted and it was published in the International Journal of Perinatal Medicine. So the talk overview today will just briefly go through these themes, that how is the disease, the COVID-19 disease, how is it unfolding in the human body? And who knows that better than you, virologists, as to how it works at the cellular level. Secondly, we'll go through the investigations and how we manage the disease as of now in the general population. Third, the pregnancy-specific considerations we'll make. And fourth, the lessons we have learned the hard way by the pregnant ladies who contracted the disease and succumbed to it. The virus, we know we call it the novel coronavirus because there's some new aspects to it, but let's be honest, we knew about this virus for many years now. We had the SARS-CoV-1, which caused a mayhem in 2002, and then there was a MERS virus, and there was a genomic compatibility to this new virus, and we have a sort of similarity of about 70 to 80% with the new one. But if you think of the closest similarity we had with the coronavirus is the strains that was there in the bat strains. Now, this is not the first time that zoonotic disease has come through and started infecting mankind. And it would be a big speculation as to how it came to do so, whether it leaked from the highly sealed animal labs or whether it's our very indulgent diet habits venturing into the exotic meat in the wet markets, we don't know. And we, all our efforts is to know other aspects and how we can save ourselves in this situation. So over the last 6-7 months, ever since WHO declared the pandemic on the 11th of March, it's been sombering thoughts. We all have been bombarded with newsline stories, photos, and we have been deeply traumatized by these pictures. And to say a few, you can see a lady hugging her mom who is infected, and that's in Spain, El Salvador. At the top, you can see one of the numerous healthcare and frontline workers who have been deeply traumatized, feeling inadequate, and seeing your patient go, you're not being able to help your patient. It's a big baggage to carry. And on a daily basis, if you're seeing that your corridors, the admission bay queued up with many patients crying out loud to breathe, they can't breathe properly and they're dying in the admission corridor, that is a huge trauma to deal with for the coming few years. And our psychologist and psychiatrist knows that it will be a big job to deal with not just depression, anxiety, but post-traumatic stress disorder, PTSD, will be a big problem for the coming years. And then hats off to a junior generation who is dealing with the e-schools and e-colleges. We know that schools and colleges are such a golden time of our life. And it's not just for the academic value, really. It's all because of the feel of walking through those long corridors, your weird traits of your friends, the signature move of your professors. Everything makes a beautiful memory of a lifetime. And I would really hope that the juniors get back their college and school life very soon. And last is the soul-tearing picture of the lockdown city of Italy, where you see long rows of the military van carrying the dead bodies for a safe disposal to outside the city. What a moment of reflection and somber we have seeing this. So as of yesterday, WHO dashboard suggests that these are the countries in deep blue, which is still the big impact countries. And so far we have already had 10 lakh people dying from this. And when John Hopkins did their engineered hotspots, and these are the hotspots around the world, and it's a bit of a speculation. We still don't know as to why a lot of the parts of different the continents has still not been affected to the extent the others are. Like you can see the Latin America, Canada, major parts of Africa and Ukrainian side, they are quite exempted from this wrath of the virus. Going back, one thing I want to clarify, which most of us know by now, the virus is the SARS virus. That's the acute respiratory distress syndrome causing virus, CoV-2, because we had the CoV-1 earlier on. And the disease that it caused, we call it the COVID-19, which is actually an abbreviation of the word coronavirus, that is the COVID, and the disease is the D, so COVID. And because it was picked up at the end part of 2019, when we were busy rejoicing our last decade and welcoming for the new decade, that was the time when at the Hubei province in China, this disease was taking its shape. So that's how the disease is COVID-19 and the virus that causes it is the SARS-CoV-2. And I won't go into the economic trauma and the injury that has been caused globally, but let's look at how the global health crisis has been brought on. And looking at, we often talk about UK, US, and a lot of other countries which has robust healthcare system. But European countries, Germany, Italy, Spain, France, they have the most robust healthcare system in the world. And for them to be on their knees, broken down, it took a lot. And the virus didn't take about more than 2 to 3 weeks to get them on their knees, absolutely. So that's the global health crisis. And the other aspect is the professional and the personal challenge. Professionally, you have to fight your own fear, anxiety of contracting the disease, passing it on to your loved ones, and also on the other hand, doing your best, physically being completely drained. And in spite of that, you feel so inadequate to lose the patient. Losing a patient is a big baggage to carry, and to come the next day afresh, giving your 100% to the next patient who is waiting for your service is not easy. The personal challenge, of course, we all have gone through that. We fear about giving the disease to our loved ones, to our family members, especially when you're working in the front line as a key worker. So hats off to globally all the workers who are helping us in this pandemic. This is the system, the healthcare system collapsed because of a killer combination. Of one hand, there's an exponential rise of this infection by numbers. So 10 doesn't become 10 plus 10 to 20, it becomes 10 to 100. The next day you get 10,000, then 10 lakhs. And no country in the world was prepared to deal with this situation. Secondly, a fixed percentage of the patients will need to go to your ICU. And none of the developed countries had such an ICU setup, which is needing like 3 to 5% of its ICU capacity. We have seen in a lot of countries within a matter of 2 to 3 weeks, militaries have put up new structures, built up new hospitals just for the COVID-19 disease, and with most of it being an ICU, and still it fell short of what we needed. And so on one hand, you have an ever-growing rise in the number of patients, and on the other hand, you have healthcare workers, which is decreasing by the day. They are contracting the disease and they are being taken out of service on a short time just because they have to isolate and you have to quarantine the contacts. So this huge disproportion of the rise in number of patients and the less number of carers, everybody was absolutely shattered. So this was quite within the first 2 to 3 months of the lockdown period in the early phase, these countries which completely showed how the infection rate just spiraled up. It was almost like a 90-degree angle it shot up, and none of the countries were equipped to deal with this. Coming to the virus proper, let's understand a bit of the, I will not go too much into detail of how it works at the cellular level, because who knows that better than you all, that the virus which gets attached to the cell surface receptor, the ACE2 receptor, angiotensin convertase enzyme 2 receptor, that is there in a lot of organs in the body. But the virus has a special preference for the respiratory tract virus, respiratory tract receptors, and they get attached, and they by the process of endocytosis, it gets into the cell, gets incorporated into the host genome, and thereby takes on the whole control. There's just a relentless replication of the viral genome, along with a lot of polypeptides, the protein that's formed, and finally, when the cell is up to its brim, all these viral particles gets assembled, and you get multitude of viral particles which is now formed into vesicles. They will come out, they'll be as if the cell will vomit it out. It will vomit out in the form of an exocytosis, leading to the destruction of the host cell, and multiple, you are talking of thousands of viral particles that comes out, who are ready to in turn infect the new cell. So that's how your replication's going on. If you're looking at the transmission is by the respiratory droplets. It's slightly different from airborne transmission, which goes a bit further, but droplets is a bit bigger size, and because it's a bit bigger and heavier, they tend to gravitate off. So from the host source, if it comes out, it will tend to gravitate off by around 1 to 1.5 meters. So if you're keeping a distance of about 2 meters from the source, from your surrounding people, you are quite safe. And if you're talking of 2 meters, we often look in terms of feet. We're looking at about 6 feet, 6 inches. That's like a tall man like Mr. Amitabh Bachchan. So there was a sad anecdote. We used to say that if you don't want people to be 6 feet above you, as in you die and you are in grave, then let's keep a horizontal 6 feet distance around us. And that's what it's all about. Now, looking at the contaminated surface, which can have the respiratory secretions, the infected particles, how long can it stay on these surfaces? Virus, we know it needs a host to replicate, but outside the body, if there's a infected secretion, it is found, let's not go into details, but overall, if you're thinking of a parcel or a cardboard box that's arrived to your house, it's going to stay, the viral particle can be alive for about 24 hours. And if you're looking at steel and plastics, you're looking at about 2 to 3 days. So if not very urgent, you might leave this untouched for that time. And if you have to touch, just go and rely on your hand washing technique. Secondly, we have also looked at whether it's coming out of the fecal material or whether it's found out in the blood. And so far, it's not separated from these specimens. So it's at the moment, it's the respiratory droplet transmission only. The last is, how about mama who, if it's infected in these 9 months, can there be a vertical or a maternal-fetal transmission? Well, we had a few cases, and all those cases where the pregnant lady was infected by the virus, all of them, their genital fluid, the amniotic fluid, their urine, as well as the breast milk, none of them was picked up, was positive for the virus. So infected mama can still well breastfeed her baby and should not really worry much about the transmission of the virus. So looking at the disease timelines, this is very important for all diseases, be it measles, chickenpox. There's an incubation period. You contract the infection, but it then replicates in big numbers and you don't have symptoms for a few days. That is a killer situation for such infectious disease like the COVID-19 disease, where it is 4 to 5 days, the incubation period, but it can stretch up to 14 days, and hence your basis of quarantining people for maximum 14 days. But in general, you tend to find this being symptomatic by about seven days. So the symptoms start and initially about 7 to 10 days, roughly looking at about 2 weeks. The symptoms will be very rampant and bad, and then slowly it will get to a resolution phase. So you're looking at, but the important bit that we have to understand at the community level is, when is this person infectious to the other people? And the person is contagious 2 days prior to having symptoms. And this is the killer part. For majority of the viral flus, the contagious period used to be 1 day before having the symptoms. But for this, which is so highly contagious, and the maximum infectious time is 2 days before starting the symptoms. Actually, the infection ability slowly wanes down by the 7 to 10 days, and slowly the person is on the way of recovery. Of course, not all of them will recover, and then we'll go through that as to what, if at all, recovery is not happening, how the progress is going to happen. So the important bit is, from the day of starting symptoms, somebody will still be infectious for about 28 days. That is 4 weeks after the start of symptoms and 2 days before the start of symptoms. A lot of countries do bring back the workers back to work within 2 weeks of the start of symptoms. And that's saying that once the symptoms are much less, the chances of infecting others is also less. But it doesn't work that way. You should remember, the viral shedding will continue for 4 weeks after. Until your swabs are negative on the PCR, they can be infectious. Clinical spectrum, grossly speaking, if 100 people is infected by the virus, vast majority, 80% will be mild symptoms. They can be well dealt with as a home isolation and staying away from the hospital. 10 of them will skip any symptoms whatsoever. And the remaining 10 of them, I've just made it as a ballpark figure for us to understand easily, that remaining 10 of them will need to go to the hospital, of which about half of them, about 4 to 5 of them, will be very critical, needing ICU admission. And unfortunately, people who end up going to ICU, about 50% of them do not make it out of the ICU. So we have a different sort of mortality rate all over the world. WHO has given a figure, Wuhan has given a figure, but at the same time, unless the pandemic is stabilized, we cannot get a very stable mortality figure. But we are looking at the moment, about roughly 1 to 2 to 3% of every 100 infected people. That's the number of people who will sadly die. Looking at what makes the disease severe in some people, and some people just escape the whole wrath of it, we will have to go understand, if you are a man, there's a double chance of you having a severe disease, making your way to the ICU, and a double chance of you dying. Secondly, if the age is over 55, more so over 60, the chances of having severe disease and dying is very high. Third, you can be quite a young person, but if at all, you have underlying sickness that has already made your immune system very vulnerable, like diabetes, asthma, people on chemo, the cancer survivors, people who are transplant recipients, kidney transplant, liver transplant, you name it, and they are on immunomodulators, lifelong immunosuppressants, so they are very vulnerable to any infection, and this is no different at all. And the other two things that I've marked as health professionals, the disease severity also depends on the load of the virus that gets in your body. You have to understand, you're not infected by one viral particle that has entered and you are infected. When you have a smallest of globule that has got into your body, that smallest of blob has millions of viral particles. And when we tell you to wash your hands properly, that's because we want you to have a less load of the virus, at least so that even if you're infected, you have less virus entering your body. So the health professionals, as you can understand, in the setting setup they work in, they are exposed to a big viral load in the air, in the aerosols around in the ITU setting. So overall, their chances of needing to go to the hospital, their chances of severe disease is about 15 to 20%, and about half of them not making it out. And the last thing, the BAME origin is it's a huge finding from mainly from the UK national studies, and it's worth understanding this. The BAME is a short form of Blacks, Asian, and ethnic minority people, and it is found beyond doubt that these people are more vulnerable to die. Of all the people who have died, there's a big percentage of this BAME population who has died, and be it in the general population or in the doctors, nurses, or all the healthcare professionals. So you have to be very careful with this group, and I'll talk about it a bit later. So even the virus has a color preference. So looking at the clinical presentation, majority of the presentation will be fever and dry cough. But as you can see, it's a spectrum of condition that you can have. And unless you ask all these conditions over the phone to triage your patient, you will miss out on quite a good bulk of your suspected patients. So unless you get into a time when there's a universal screening for all, you have to do a telephonic triage with all these potent questions, and then you will find your possible suspected patients that you will be swabbing them for. But majority, as you can see, fever and cough will be in 80 to 90%, but again, 10% will have none of those symptoms and will just have a bit of body ache. There can be a superimposed bacterial infection with some phlegm production. There can be a transient viral diarrhea or gastroenteritis. And 30 to 40% of the patients has strangely been found to have loss of taste and smell. And in a few hospitals in Europe, in Paris, they have already started doing this, that what we do in UK, once we do a telephonic triage and we bring them, we check their temperature first, send a blood test for the C-reactive protein, an inflammatory marker. But in Europe, a few of the hospitals is also keeping a very strong smell substance like a castor oil or a peppermint oil, and they're asking the patients to smell it. And if they can't smell it, you are again picking up a big cohort of patients whom you have to test. Again, not all of them need to have a chest x-ray. A small half of the population who are infected will have the disease going down to their lungs, causing a lung infection, that is pneumonia. And if you do a chest x-ray in all of them, only half of them will have the pneumonitis-like features, which is the glass ground opacity. And you can see that all in arrows there. Sometimes they will just they will be quite multi-lobar. They will go from one lobe to the other's extent, or maybe even both sides. So that is the extent of the pneumonia that a patient can have. And below you have all the cross-sectional plates of the CT scan thorax, where on the top line you can see the pneumonitis-like changes, the inflammatory exudates that there can be. But you can well see at the bottom line, I don't need to say what extensive damage there has been. There's been inflammatory exudates, there's scarring, there's fibrin deposits, and hardly any bit of the normal parenchyma that there is left there. So in the blood test, I've marked in deep the markers which are for the severity of the disease. And if these markers are going high, your patient is not doing well. So regarding the natural course of the disease, first after the incubation period, the viral replication is at its peak. So after maybe the first week of incubation period, you'll start having the symptoms. That is the stage 1 of the disease, when the virus is still replicating in big number. But after a week or so, either the symptoms will resolve or the virus will reach to the lower respiratory tract, that is the pulmonary phase, and you get the shortness of breath, the chest pain, the distress increasing, and they might need to come up to the hospital. But after that, the viral replication will slowly wane down and you will have a sort of a way towards recovery, unless you have the other arm of the patients who are not going to recover and will be more and more unwell. And that is because of the exaggerated host inflammatory response that is triggered. Now, let's understand, be it a virus, be it a bacteria, they are all enemies to our body. And when they enter our body, the body knows there's enemies in the forts and castles, and they will send their army to fight it. And these armies are like the natural killer cells, the T cells, the big macrophages, the giant cells. They will all go to fight that enemy and swallow it. But as they do that, there is a lot of in some toxic mediators, some pro-inflammatory markers, which are very detrimental to our own body. Like if you go to the battlefield, after a point, you get so overzealous, you forget who is the enemy and which is your home territory, and you start burning your own forts and castles, causing big damage. This is exactly what happens, that when you get too overwhelmed in the fight and there's so much toxic material that's produced, your own body gets overwhelmed by these toxic material and cannot deal with it and starts sinking. So this is what we call as the cytokine storm, and we still don't know why some people will have this immense storm and those people will sink in their own fight response. A fight that was meant to safeguard their forts and castles is now drowning their own territory. So we do not know whether there's any genetic predilection, or along with that, the risk factors mentioned earlier. So once this fight starts, a lot of pro-inflammatory markers like the interleukin 1, 6, tumor necrosis factor, you name it, cytokines, numerous type, and these damages all the blood vessels to the point that there will be a fluid leakage from the blood circulation, and the patient will look swollen, they'll look edematous, and that swelling will happen inside all your body organs as well. There will be waterlogging in the lung. Think of the lung, which is meant to just do the filtration. It has to get you oxygen, give out the carbon dioxide. If there's waterlogging, like a pulmonary edema, the patient is running short of oxygen and will be agitated, sweaty, and not really responding easily. Then you'll have cerebral edema, like your brain edema, and the patient will be not so easily arousable, almost comatose. And these will be the last stages of the disease when you completely lose control. Along with that, the inflammation leads to a huge cascade of a disseminated intravascular coagulation, leading to blood clotting in the smallest of pipes, the blood vessels, leading to end organ damage. You end up having stroke, you end up having myocardial infarction, a condition where there's a multi-organ failure starting. So looking at the diagnostic test, there's a lot of confusion in the general population as to what test shall we do. Shall we do a swab test or a blood test? So let's understand, you cannot just pick one and think the other isn't useful. They're both complementary, but you have to understand what actually these two are showing you. When you talk about the swab test, which majority of the UK hospitals, we are doing only swab test, and that is at the bedside. You do a nasal Q-tip or a nasopharyngeal long, that swab that goes just past the hard palate uvula and touches the back of the throat. There's an immense gag response. The patient will start coughing, but you are taking the respiratory secretions from there, and that's being sent to diagnose the viral genomic particle by PCR. The PCR has been now available in most of the countries of the world, and we are looking at PCR results. You get it within 1 to 3 days. And now most of the places will get it within 12 hours. But we have now moved on to the real-time PCR, which the results are available to us within a matter of 1 hour. So that has completely changed the way we are diagnosing our cases, and the results coming very quickly. But this is the swabs that we are relying on, because then you can pick up on the acute cases who have contracted the disease in the last 48 hours, 1 day, 2 days. They will be in the nasopharyngeal secretion. But again, like any test in the world, nothing is 100%. And if 100 people are infected, you are looking at a PCR result, they will show about 60 to 80% of the result will be positive. So you will still miss out on the 20% of the people who are infected and giving a negative PCR result. So if you have a high suspicion that the patient might be infected, you repeat it. Looking at the blood test, why it's not done in the UK and why it's not so useful in the day-to-day clinical practice is because it's going to pick up on the antibody. The antibody are fighting army that is made against the foreign body, the bacteria, virus, you name it. And this production takes time. First, the IgM is produced within a matter of first 1 week. And then after about 2 to 3 weeks, you have the production of IgG. So if there's IgM in the blood, that says there has been a recent infection. But then if you do the blood, a majority will be negative in the first 1 to 3 weeks. And we cannot be waiting that long, can we? So this is still as a research level we do. Yes, if you are doing a bedside strip test, like a pregnancy strip test, a drop of blood is given, and then you watch out for 1 or 2 lines. And the better lab one is the ELISA test. And again, the ELISA test will say, yes, this person was recently infected, but you cannot pick up the acute cases if you are going to wait for these immunoglobulin information. Secondly, the IgM will be there only for the first few weeks to a couple of months and then will wane down, showing it's an acute response. But the IgG shows that it was a chronic infection and they tend to stay in our body for a good few years. That is the whole basis of your vaccination, that the IgG stays as a protector for future infections. So again, if you have IgG, you have no clue whether this man was infected 6 months ago or a month ago. We don't know. Coming to the treatment, there's a lot of treatment that's on trial and we won't go into that. But just to highlight, in the initial viral replicating phase, stage 1 and stage 2, there is a role for antivirus, but which will work better. Big researches are ongoing and we are still waiting for some results. Some are trickling in every day, but we have to keep our eyes open. And secondly, if at all there's this hyperinflammatory phase that's taking over and the patient is not resolving, getting worse by the day, you'll have to think of the anti-inflammatory immunomodulatory therapies like anti-interleukins, anti-tumor necrosis factors, looking at the steroids, and etc. So they have their own role and a lot of countries has been using them, because in a pandemic situation you just have to use and see what happens, provided it's an informed consent from your patients. And lastly, because there's a widespread coagulation of the small blood vessels, you need to use blood thinners so that there's no end organ damage. It doesn't block the blood circulation and doesn't cut off the oxygen circulation from different organs. So that's your whole world of pharmacology, the different drugs that's out in the market that has been used for the previous viruses, similar coronaviruses, and which all targets the different phases of the viral attachment, the replication, the polypeptide formation, and with the hope that we will get some good information at the end of a few months' time. As a clinician, I cannot, we all know these preventive aspects, and believe you me, we can talk about all the medical jargons and the few things that's there in the scientific world that's coming on a day-to-day basis. But what will save life of millions? We know it's these simple preventive measures of hand hygiene, going back to basics where are robust, you have to go on a very meticulous hand washing. Believe me, most of the places you are just okay with washing your hand with the normal soaps and detergent that will take away majority of the microbes. You don't have to go for the 70% alcohol. But regarding the hand hygiene, it might sound very patronizing, but I'm going to go through it some things because, as I said, these simple things will help huge number of lives. And I would be very grateful if all of you, I'm just going to show you a hand washing technique which we surgeons do that every time we clean ourselves and get ready, dawn into the OT theater theater gown. And that surgical hand washing technique is the way that you can take away majority of the microbes from your hand. And it seems like, what the big deal is it? There is a big deal, believe me. If there is ways of showing you, there's so many parts of the hands that we don't even wash when we think we have washed our hand. So it will be great if you can watch me, rather than, there's so many places in YouTube, these charts are there. But can I request all the audience members to do what I'm showing you, and promise me you will show this to all your kids at home, all your elderly family members, all your friends. This is how we are going to help each other. So simple things, 6 steps we will go through. So wet your hand and take the soap. I hope all of you can see me. Take the soap on your hand and just spread it over. All of you, please do this, because it's going to help you seriously. So just spread the lather. Okay, once the lather is all spread, step 1, there are certain parts of the finger which will never clean otherwise. Step 1, on the palmar aspect, in between the fingers, you are going to scrub. Step 1, take your time to do that. Then comes step 2, in between the fingers from the dorsal aspect, we are going to do this from the dorsal aspect, and on the other hand, that is step 2. Okay, so we are going to touch all the parts of the finger and nothing will be untouched. Step 3, lock your hands and scribble this so that the dorsal aspect of your fingers are all cleaned. That is your step 3. Then the thumb, we haven't done it, have we? Step 4, go onto your thumb and wriggle the base of the thumb. Take away the microbes from there. All right, do the same. Step 4 on the other thumb, and just do it. Wriggle the base of your thumb. Okay, now the fingertips. I don't want to comment on people who love to have their nails, but we should trim our hands, especially in the times of pandemic. And 5, make a cone of all the fingertips and just clean your fingertips. Step 5. Step 5. All right. And last step is wriggling around your wrist. And that is your step 6. So going through that once again, step 1, in between the fingers on the palmar aspect. Step 2, from the dorsal aspect on both sides. Step 2. Step 3, lock your hand. Step 4, around the thumb. Step 5 is the fingertips all made into a cone, and take care of your fingertips, clean them. And step 6 is the wrist. Now, of course, we know about the physical distancing and the hand hygiene. And if you are in close proximity with other people, you have to think of gowning, your face shield and everything. But a few moments of few information about the mask, we have to go through that. There's a lot of confusion and worry about what mask to put on. And I'll tell you a few things that you need to clear your information about it. Be it the homemade mask that you're making from the home cloth. Yes, of course, not the best. And there's so many guidelines as to which is the better one. But look at, these are also easily available in the market. The surgical mask, the blue one, that we normally don in the normal setting hospital, in the theaters. Now, these masks, they will help you. They will stop the big any body fluid or a big splash on your face, and they will stop that from going. But none of that will stop any of the microbes from reaching you. So isn't that worrying? You often worry so much, oh my God, I forgot to put on the mask. The mask is basically to stop your own secretion from coming out of your mouth and face and traveling far. So if you put on a mask, you're not safeguarding yourself, but you're safeguarding the other person who is next to you. So for you to be safe, that other person has to put on a mask so that you are safe. So your mask is saving other people, not yourself. They are not at all tight, snugly fit on your face. So don't bother much. Oh my God, am I safe or not? You are actually, as a community, you are helping each other. So everybody should put on a mask in the peak of a pandemic. Similarly, a lot of y'all think, oh my God, I didn't have the N95 and all that. So the N95, how did the name come? The name came because because the companies say that it's going to stop 95% of the particulate material that's floating in the air. And that's how the 95, you have 98, N98, N99, depending on the filter they have given, and that's going to stop 98 or 99% of the particulate organism. But again, this is not going to stop everything. You will be amazed to hear that there is a clear sort of, from the company, they have said their filters are only meant to stop 0.3 micron and over, a size of 0.3 micron. Each micron is 1/1000 millimeter. So if you're looking at that, that's going to stop 0.3 micron and bigger particles. What about the smaller ones? And by the way, most of the virus and your coronavirus is about 0.1 to 0.2 micron in size. So none of that is being stopped by that filter that you're using. But yes, there's been various research saying that if you put on that mask in a very high risk setup like ITU and all, the risk of having respiratory disease is much less. That is one. So research does say it somehow does make a barrier. And secondly, the manufacturers, and a lot of research has gone on, they have said how they help is the filter doesn't really stop, but what works in that the mask material that has an electrostatic power that generates, and that the viral particles, the air particles start getting stuck with the electrostatic charge, and then once they go through the mesh of the viral this mask fabric, they have a random zigzag motion like a Brownian motion, and they get tangled in the whole lace of that mask fabric. And hence that specialized mask you shouldn't reuse, because your viral particles is actually got stranded in the lace inside it. It's not the filter that has helped you. So coming finally to the pregnancy, who is a special niche in our general population, overall pregnancy and pneumonia does not do well. So if at all your coronavirus has ended up going to the lower part of the respiratory tract and you had end up with a pneumonia, think of a mom who is inside whom another life is building. There's need for more oxygen. There's need for more blood supply. And as it is, the lungs cannot expand so well at the end part of pregnancy because the growing baby is splinting on the diaphragm and pushing up on the lungs. So you have less space. On top of that, if there's a lung infection, you are in trouble. So normally, any form of lung pneumonia, about 1/4 of these pregnant women will need to be hospitalized, and a big portion don't make it. And you can well understand if the lungs are not working, that's where you get your oxygen to your body too. So hence the babies are prone to growth restriction, dying in uterus or outside as an early neonatal death, and all these problems can happen. We have to rely, COVID-19 is still a relatively new, still 6 months on, but still new. We have to rely on our experiences that we gathered from the previous seasonal flu that used to hit every year. Now, trust me, every year the flu virus becomes so rampant, and you still used to have people dying from it. But that dying mortality used to be as much as like 0.5%, but here you have a mortality of about 2 to 3% clubbed with such high infectious, contagious nature. So our last big pandemic that we had was, I still remember, it was in 2009 and 10 that you had the swine flu, H1N1 influenza virus that caused a mayhem. And about 30% of these infected women who are pregnant, they used to be hospitalized with very severe pneumonia. But there is good news. If you do a comparative study of the virulence of all the types of most common types of the coronavirus that we knew about the SARS-CoV-1, the MERS virus, which are all different variants of the coronavirus, and the SARS-CoV-2. So they are color-coded, and a few of them, there's not that big meta-analysis that you will find, but a few case reports that's done from different parts. You would see overall, the SARS-CoV and the MERS virus, the chances of if pregnant women gets infected by that, about 40 to about half of them ended up needing to be hospitalized. Big proportion of them, about 1/3 of them died. Unlike that, at the bottom, the green part, you can see with the SARS-CoV-2 or the coronavirus disease 19 that we have, there's a very small proportion of women who are hospitalized with severe disease. Very small proportion of women dying, and the babies are also doing so well. So with the MERS virus, you can see about 1/3 of the babies used to die. So there's a huge difference in how our pregnant population is interacting with this new coronavirus, and it is definitely a good news. So the facts for any pregnant women, of course, in a pandemic, everybody is panicked, but you have to tell them so far that you are not. If you are pregnant, it doesn't mean you are more vulnerable to get this infection. It doesn't mean you will get more severe infection. However, the chances of having severe disease is more if you are in your last part of pregnancy, that is the 3rd trimester. And if you end up having a severe disease, unfortunately, majority will die. But the chances of having severe disease is very, very low still. And because there's no vertical infection transmission found, neonatal newborns are hardly found to be positive for the virus. There's been very few cases, and still we don't believe it's because of the vertical transmission from mom. We still feel that it has been a contamination or infection from surrounding. If you end up having an unplanned pregnancy and wanting an abortion in your early stages of pregnancy, in UK, we are doing a telephonic triage and home dispensing the medications for them to self-medicate and come to the hospital if there's any warning features. And if you are thinking of going for subfertility or IVF treatment, it was all stopped during the lockdown period, but they are all open with the new guidelines. They all follow the new norms. But it's up to you. If you can delay it for a year or two, that's the best thing, because you have to remember in an IVF, each cycle, you will have regular follow-up. You need close proximity ultrasound scanning on a regular basis. If you're not mentally up to it, please don't start your cycle and delay it. Looking at the pregnancy-specific risk, we won't go into these details, but there's a spike of the C-section operative deliveries with initial thought that we are going to help the moms and reduce the infection, the disease time. But actually, that's not the case. Moms can well have a normal delivery, and you are actually increasing risk to a lot of health professionals if you take them to theater for a C-section. So do not do that. A lot of the severe COVID condition does mimic hypertensive disease of the pregnancy, or for clots, which are big killers, but it is very difficult to differentiate, and you need a multi-team discussion to understand which way to go. It's been a challenge to reorganize the whole department to fight this COVID. And again, I'm just going to go for the highlights. That first, the basis of reorganizing is one, you have to think how you will cater for these infected moms. And for that, you need the national, and every health board needs a guideline and protocol to do it safely. Second, you have to break the transmission chain. And that's not just the hand hygiene, that's the personal protection, but you have to reduce the footfalls. You have to stop the patient family members and partners from coming. This is hugely traumatic for a pregnancy experience. We are moving to telemedicine appointment, and a lot of my patients have come to this clinic and said, "Doctor, can we do FaceTime? My poor husband is waiting in the parking lot, and it would be wonderful if we can involve him too." Think of grouping your tests so that you can do them in one sitting and don't bring the patient back many times. Rely on the telephonic triage. Go through those set questions to make sure you're not missing out the suspected patients. And lastly, reorganize your resources, your beds, your staffs. You have different zone, the red zone and the green zone, and the staff from red zone will not go to the green zone patient that day. And you need quick bed turnover, so quick home discharges and telephonic follow-up. This is in New York. A study showed why should all hospitals think of universal screening of all their pregnant mamas, because of all the 100 people who come to the hospital door, about 15% of them, if all of them is checked, you will see out of every 100, 15% of them are positive for the infection. of which only 1 to 2% of them had symptoms, and the other 13% of them were completely silent. So this is why you should move to the universal screening. And very important, if you see on these people, the animations that we have said, why is it important? If you have somebody who is symptomatic, you will take your precautions. That person will not be transmitting it to you because you are careful. But if you don't know a person, completely asymptomatic, those are the causes of spread of the disease to the health professionals, other patients. So hence the asymptomatic cases are the killers. And at the peak of the epidemic in New York, they did another study which did say that at some point at the peak, they found about 50 to 80% of every 100 moms were found to be positive with the infection. Such high infection rate they had at one of the study they showed. So this is going to help you. Doing a universal study will actually help the public health policy making as well. So decision on the level of care, not all pregnant women who are infected, they doesn't need to come to the hospital, doesn't need hospital admission. I mean, they can be well managed at home with close communication and follow up with the health professionals and making sure they do their symptomatic therapy, stay rehydrated, use paracetamol and the simple measures. But they should all be informed that these are the warning signs, the red flag signs when you should report into the hospital. That is, if at all your symptoms are going on for a long time, after 1 or 2 weeks, if you're still having high temperature, if you show signs of distressed, labored breathing, signs of pneumonia building, if you already have other sick conditions, hypertension, diabetes, or if you are from the ethnic minority people, and if you have confusion, if you have a high urea level, that means the renal function's not working well, you are breathing very deep and troubled, you can hear somebody breathing as in wheeze or as in very troubled breathing from, these are already quite severe situations, and you shouldn't even wait for somebody to help. You should straight away get the patient into the hospital ASAP. So regarding the pregnancy management, just overall, if you know that you are infected in pregnancy, you should notify your health professionals and inform the public health people, because this is a notifiable disease. We know very little about it, and every disease should be informed so that we have a national registry and we learn from those. Secondly, the usual precautions. Thirdly, keep the mama informed about the possible risk factors and what to pick up and what we will do in those situations if things worsen. And yes, definitely home treatment is an option. And at intervals, you have to scan the baby and make sure baby is growing fine. But gone are those days you would just go private and do reassurance scan. This pandemic is not the time to do the reassurance scan. You should only do scanning if there is a pressing need for, like a suspected malformation, if you have a very growth retarded baby and you think the scan is going to help your management, then only you should do it. This is one of the view of our delivery suites, each labor ward room where the patient come to deliver in a low risk setting. You have the pool, they can opt to have a pool birth, which is at the moment taken off because in view of the pandemic, though we haven't seen any fecal transmission, but we still don't want the baby to be coming out in the pool. But water birth is a very good pain relief option, and you have all the setup for the patient and the family, the partner, birth partner to be there. During delivery, again, the same precautions that goes for the patient as well as the health professionals. But I will just touch on the fact that if you are infected, mom, it doesn't mean you cannot breastfeed your baby. We haven't still found it's getting secreted in the breast milk, and WHO will say it is still more beneficial to breastfeed. But of course, you would think of taking all the precautions to keep the distance, to put your mask on, to have a hand hygiene. And the important thing is that you can even think of expressing your breast milk so that somebody else can feed and you can keep a safe distance if you're infected. Coming to the last bit, just to highlight a few very important findings from the UK study, that with 1.5 months into the pandemic, UCOS, the UK Obstetric Surveillance System, which every year puts up a list of 4, 5, 6 disease conditions which are extremely rare. And to have a pregnancy with these disease conditions is even rarer. So every year they put up a list and they ask all the UK hospitals to notify if they have any pregnant women with this disease condition, which is so rare, to report how the patient did so that we can learn from those case reports. So UCOS, again, this year, of course, COVID-19 is what they're looking at. And within 1.5 months into the pandemic, looking at the 1st of March to 14th of April, 94 hospitals in the UK, there was 427 pregnant women who was admitted in the hospital with COVID. Not the number of patients who had COVID, but who had disease severe enough to be admitted within 1.5 months. And they found that the mortality rate, moms who died, was about 0.5 in every 100 maternity. Yes, it's all very sad. Each mom, losing each healthy mom is very sad, but the mortality figure is much less than general population, where it's about 2 to 3%. Here it's about 0.5%. So that is reassuring news. But the big thing that I want you all to see is 56% of these attending mamas were Black and from ethnic minority, Sudanese, Egyptian, Asian community, everybody. And if you think, what's the big deal? It's only half the people. The big deal is, in UK, 15% of the population is Black, Asian, and ethnic minority women. And if 15% of the population, and when you have people getting admitted with severe disease, half of them are that, you can see the huge disproportion to these people. And most of them were in their third trimester, last trimester, but the outcomes were good in most of them. But this is the unfortunate report that the moms that we have lost in UK at this pandemic in the first 3 months. And this is the Membrace report. Membrace does focus on moms. Every mom who dies in the UK, they compile the results, they pull up all the stories in a very anonymous way so that you can't identify mom or the hospital, whatever. But every failure is a learning lesson for the next, for the whole bulk of healthcare professionals. And every 3 years, they bring out as a report, a confidential report of all the mamas who have died. And that is like a manual we read to learn from their mistakes. What went wrong? Why should a healthy mom who has just come for a beautiful experience of a childbirth breathe her last? So from the COVID-19, 10 moms died within a matter of 3 months. So they chased from the beginning of March till the end of May, and there was 10 moms who passed away. Most of them, all of them gave birth to their newborn. All of the babies were healthy, save 2 of the babies were dead at the time of birth, stillbirth, but 7 of them passed away from direct complication of COVID-19, and 3 of them were victims of, they passed away because of suicide and domestic abuse. You have to understand mental health, and it's all our owners now. Mamas are freaking out, not for themselves, but because of the risk they might do to their newborn if they are infected. And if they are really confirmed infected, think of the mental trauma they are going through, and also the domestic abuse that gets accelerated in these times. So again, we have to support the mental health aspect very much, and see the striking thing, 7 of those 10 mamas were from the Black and ethnic minority group. A very, very sombering thought. This is the last piece that I want to say. Last week, it was one of our work that got published in an international conference, Birth 2020, and it was mainly to find out the psychological aspect of the mamas, how they are coping in this pandemic with the huge changes that we had in this COVID-19 situation. So a few things just to say, the pink are that they are worrying, and there's a lot of pink you can see. They're worrying about the less community midwife visit. They're worrying about the less ambulance availability. They're worrying there's no pool. They're worrying about their partner not being with them for a long time, and the fear of the unknown. So half of them said it was a lovely experience, but 10 of them found it's very traumatic experience, and it might put off for their life to deal with this. So not everybody takes it with a bold, is not able to take it with a bold strand. So the negative comments was, it was a constant fear of the unknown, and it was extremely disappointing for the birth partner not being there with me for a long time. But majority said, we are so grateful. It was a positive experience, and the way we were catered for. So in summary, we should say to all our pregnant at home friends in the community, we should pass on this message that it's okay to be pregnant in this pandemic even. And if you are already pregnant, do not freak out, but just continue isolating yourself, and go out if only that's really needed. Do your hand hygiene and offer them reassurance, because they are not more likely to be infected if they are pregnant. They are not more likely to have severe disease. Vast majority of them are having good obstetric outcome for both mom and baby. And there is still no evidence that it increases the risk of pregnancy loss or congenital malformation for the baby. However, we still have to track these positive moms. We have to check their babies for years at a stretch to say that for sure. And hospitals, we are trying our level best to make you and your baby safe and to give you a very rewarding experience. So feel free to come when you need to, because we have seen scared parents and their children. They're not coming to the hospital unless it's very late, and that's not what we want. And lastly, data is still limited. It's all our owners to report every cases to the health professionals, to the national registry, so that we can learn more. And together, we can definitely change this whole pandemic scare to a very rewarding experience, and not make it a lifetime scar that will be a trauma for you to remember. Definitely not. With that, I want to thank you all, and I stop here, ready to take questions. I think I'm surely chewed up on a lot of QA's time. And these two pictures were sent by my dad this morning. So there we are. Thank you so much, everybody.
Now I request Dr. Arup Kumar Mitro to present the questions that were asked via the chat box. Sir.
Yeah, at the outset, I would like to express my gratitude for the wonderful talk, wonderful coverage. You started with the introduction, what is COVID-2 all about, and then you went into other complications, different other organs in different countries, the global scenario, and then of course you touched upon the UK, the complications, and of course prevention is better than cure. I would definitely appreciate the way you explained how to wash the hands, and if we can practice it, then we can actually prevent it. Simple things, but these are so important. And last but not the least, the way you explained the pregnant woman, the risk, and how actually that can open a new research, that why the ethnic and the Asian people are more affected and the mortality rate is higher in pregnant women. But there has been some questions. So if you are ready, then I can just read out the questions one by one. Can I?
Yes, please.
Okay. So this is a question from most of the students. They have asked. They have listened to your lecture very carefully. What is the relationship between COVID pneumonia and vitamin D deficiency, and also high level of TSH? This was a question from Ananya Dotto, a postgraduate student.
So regarding the vitamin D, there's been a lot of study that the vitamin D in general has a boosting effect on your immunity, Ananya. So it is not directly linked to stopping the disease from happening, but there's been a lot of vitamins, vitamin D, vitamin E, which is being studied at, which is going to boost your immune system, and that's how you will combat from having the disease or a more severe disease in a way. Regarding TSH, the thyroid stimulating hormone, I'm not aware of any study that has come up with a valid data so far that if you are hypothyroid, I mean, that's a very interesting thing. If you're hypothyroid, you have a high level of TSH, and hypothyroid people are a bit prone to obesity, okay? And the obese population does contract the disease a bit more than the others. So you can have a relation of the TSH with having the chance of having the disease, but that's all I can say at this moment.
Okay, thank you. Now, there is another question. They're saying that high level of antibodies in general through some mechanism can combat COVID-19. Is it true to tackle this threatening infection?
See, the antibody production is the whole basis of what we have in vaccination. We try to generate antibody, but it's not about the number. What we try to do is to give the body a memory for future. Once it remembers that this is a foreign body, this is an enemy to us body, if that enemy enters our body in future, body has a way of remembering, and it will form antibodies in big number to fight that in future. So it's not really a lot about the antibody titer at that point, but it's about reminding the body that this is a foreign body, remember this, and in future if you get infected, these antibodies will again be formed in big numbers, and they will help you to have a less severe disease.
Okay, thank you. Now, this is a very interesting question. This is from Srijit Saha, another student. He's asking that adjuvants are actually used in vaccine, but should they be used because they also increase the cytokine storm? Because cytokine stimulating property is there in adjuvants. This was his question.
Tell me the question again, please. What's the question
He
again?
is asking that should adjuvants be used against COVID or in preparation of COVID vaccine, because adjuvants directly is responsible for increasing cytokine storm.
That is a question for you scientists to say. The base adjuvant that's there in a lot of vaccines, again, that you have to go through that which adjuvant has the less potential to cause allergic response, and you have to go on the most inert adjuvant. So you are right, it can cause an allergic response by itself, and we know about that from a lot of previous vaccine. So yes, you need a base, but what adjuvant, how inert adjuvant you can have, because a lot of them do stimulate allergic response, and you won't want that. So I would leave it to the scientific world to deal with what they can use as a safe adjuvant for this vaccine that they are producing.
Another very interesting question from Shayantun. Actually, the question was not complete, but I am completing the question. He is saying that 20 to 40% cases may not be detected by RT-PCR. So these cases are undetected. They go undetected. That means a very mild sort of infection. But are they real threat in spreading the disease?
Wonderful question. Let's be clear on this. The out of 10, we spoke about the percentages. In every 100 infected people, 10 of them will skip any form of symptoms. That is, they will remain asymptomatic. And these asymptomatic people are not the biggest threat in the community. They are asymptomatic because their viral replication has also been mellowed down, tuned down. So they still are contagious to others, but they are not a big threat to the community. In terms of the symptomatic population, where you're not doing any universal check, for the symptomatic people, if you are doing a check, yes, every test has its sensitivity, and the ones that you are not getting a positive result, number one is you have to have a low index of suspicion. If they are still continuing to be symptomatic, you will have to repeat the test at a later date, because today it can be negative, tomorrow another PCR might have the ability to pick up on the RT-PCR. That's one. Secondly, before starting the symptoms, the 2 days prior to having the symptoms, when they're completely asymptomatic, that is the time of the biggest viral replication, and they're most infectious at that time. So yes, this is the big threat to the community, where we deal with everybody and 2 days after we hear that they had symptoms. So that is why we have to limit our interaction, we have to put on the mask, and yes, that physical distancing rule, because they are a big threat. The asymptomatic people who will be symptomatic in 2 days' time, not the asymptomatic people who will not develop symptoms because they have a low viral load.
Thank you. Thank you. Somewhat similar type of question. Again, it is a intriguing question. There's some people may have, this is from Anish Pine, another ex-student of us. He was asking that if a person is having high level of IgG or IgM, then that person is suffering to some extent. He is carrying the COVID virus. But do we consider her to be infectious? Already the antibody load is high. So expression of the disease is low. Somewhat this is similar. Question is similar.
Yes, this question again will clarify this. A person is only infectious when the virus particle is in the upper respiratory tract, and that is picked up by your nasopharyngeal swab with a PCR. We should get people back to work after infection only when the throat swabs are negative on the PCR. We cannot rely on the immunoglobulin level and the assay to determine whether they are still infectious or not, because this is a body's immune response, and the IgM will last for a few months to say it's a recent infection. IgG will last for many years to say that this person was once infected by the virus, but doesn't say whether this person is infectious at this present moment and is a threat to the community. For you to get that answer, you need to do a throat swab PCR, and that is why we are only relying on throat swabs.
Thank you. Thank you. This is also a question from Riddhita. She was asking that steroids are often given. Prednisolone is given to COVID patients for recovery, but it also increases the blood sugar level. So that will not increase the risk for diabetic patient.
Wonderful question. And these are all in the research remit. And that is the whole problem. With steroids, there has been contradicting different sort of study results that has come. Steroids has an immunomodulatory effect. And when the patient is quite critical, and you know it's the hyperinflammation has taken over now, and the patient is drowning in its own immune response, you have to dampen it by using some immunomodulators, and steroids is one of them. Very true. So there has been big trials, some medium-sized, biggish trials that's going on, where they are using it for critically ill patient in the ICU, but they still haven't got good big result. But there has been some breakthrough that the patient have made it from being critically ill. We still do not have enough data to say steroids is helpful, but definitely it has a role to play in the critically ill patient. But of course, in medicine and science, it's a dual-edged sword. You're so right. Steroids has a hyperglycemic activity, and the blood sugar level will go high. And this is the time when we'll have big meetings to think which is a bigger killer. Will we take a steroid injection and put her at a more risk of high blood sugar, because that's going to invite more trouble with an ongoing infection? So yes, in these patients, we might be quite cautious and may not be able to use it in these patients if it's an uncontrolled diabetic patient we are looking at. It's a very good question. And these are the points where we have MDT meeting, multidisciplinary team meeting, where all the heads sit together and think of which is the best way to proceed in this situation. Thank you.
Thank you. Thank you for the answer. This is already answered because there has been recurrence of the infection many where it is reported. So one was asking that, Renu was asking that, is there any possibility of the recurrence of the disease? It is already reported. But I am adding to that, is there any possibility that the first time infection was very mild, but in the second infection, the wave is even higher in the same person and can lead to death. That is my question.
Okay, there has been few reports of people who was found to be PCR negative, and within a few weeks to months they are found to be positive. Now there's a contradiction in this, and a lot of scientific body does feel that this is not a reinfection. Going by the theory of immunoglobulin production, they say that because all the tests have a sensitivity that it's not going to pick up 100%. When you had the PCR negative, there's a possibility this person was never negative, but you had a false negative result, and this patient was never better, and it actually harbored for a long time and then slipped into a very critical situation. Scientists are still not happy to believe this is a reinfection happening within a matter of 3 to 4 weeks. They feel that this was never a negative case, but it was a false negative result on the PCR.
Okay, I understand. Thank you. This is also another interesting question. Actually, this is about mask. Now, one Aniket Ganguly, he was asking, N95 mask, if we wash it, does it lose the efficacy? I think yes. Anyway, answer is up to you.
Yes, not recommended for the N95. You can definitely wash the homemade mask. And as I said, the mask is only a barrier. It's not going to stop all the microbial particles. So to make an additional barrier along with your 2-meter distance is what's going to help. You can definitely wash the homemade masks and use it. Also a good idea to leave it for 2-3 days. Even if you wash after that, reuse it, but not the filter respiratory masks.
I will ask 2 more questions. This is final, then I will stop. Now this question, again, one guy, Rishi Modok, he was asking that about the psychotropic drugs which are being taken because of psychological problem. And he was actually, didn't complete the question, but what he wanted to say, I am asking that how actually is it modifying the defense system, or how it increases the COVID survival or survival possibility, or the other way around, morbidity in a particular case where an elderly patient or even an adult patient is taking psychotropic drugs. So does it, do we recommend this psychotropic drug to continue, or do we stop because you are COVID infected at that point of time? Or even after you have recovered, because already there is a lot of psychological problem. So these drugs, if you don't take that, you can get more worsened in terms of your psyche. So that was the question.
In depth, I won't go into this because this is a question should be taken by my psychiatric colleague. But overall, in general, if somebody is needing as much as psychotropic drugs and not just a mild sedative or helping with depression, so if at all somebody needs psychotropic drug, the answer is you should not stop it, because there is big chances of your mental health to worsen anyways because of the COVID panic, worry, and you should not stop it. What I'm not aware of is whether the psychotropic drugs also increases your predilection to have the infection or to have it more severe. I'm not aware of this. I'm happy to dig into this and get back to who asked this, but there we are. The answer is the medicine should not be stopped for sure.
Thank you. And this is the last question, final question. We do suffer from autoimmune disorder, and autoimmune disorder, actually we can take some immune suppressor drug, and if a person who is taking, say, IFN receptor blocker, does it going to help in terms of COVID infection? So the risk will be reduced. So, or it is the other way around? This is the question.
For any autoimmune diseases, right?
Yeah, because immune suppressor drug is very common. This is being prescribed all over the globe.
Yes. So your question regarding that is whether
if there is COVID infection, ultimately that immune suppressor drug will do good, because I think that cytokine storm will be reduced. But is it true that it will be helping that patient and the morbidity will be reduced, morbidity possibility?
Sure. We are only 6, 7 months into the, we don't have answer to this, but in general, again, autoimmune condition, and if you are on some immunomodulatory drugs, again, the answer is you should continue it because you need it for your any regular medication that you're on. You should continue it. But if it's going to, the answer that you have wanted, whether it's going to make you more vulnerable to the infection or help you, the answer is I'm not sure of at this point in time. I'm not aware of any studies on this line, but again, that's a very good question, that whether receptor blockers and autoimmune mediators, whether that will interact with this condition. The answer is I'm not sure at this point in time.
Thank you. Thank you very much. Now, I think the MC has to say something, but before she says anything, actually, these 2 hours, almost 2 hours, you were lecturing and I was listening all the points and I actually listened to your answers. It's wonderful. You are a wonderful teacher and you are also a good researcher, and at the same time, you just call a spade a spade. That is a good thing that one researcher should have. Should not conceal anything and speak out at every point where it is required. So I really thank in the Zaverian spirit. Thank you, Nandini ma'am, for your wonderful exposition, your expertise, and your wide coverage of topic. In a short time, you did justice to your lecture. Thank you very much. And we all appreciate in our heart. It is not an auditorium, it is just a platform, a virtual platform where we can clap, but the claps will not reach you. But we all have clapped in our heart. Thank you very much.
What an honor and privilege. I'll savor this memory. When your own sir calls you ma'am, that's a special day to remember. And you are the guru without whom I would have never been able to step into the world of medicine. So let me thank you today in front of everybody.
My privilege. Over to MC.
Thank you, ma'am, for your enriching lecture. It is an honor to have you amongst us today. And thanks, sir, for graciously moderating this session. Now I request Dr. Arup Kumar Mithru to kindly hand over the e-bouquet, e-memento, and e-certificate to ma'am.
Okay, so I cannot hand it over directly. So over the computer screen, thank you very much, madam. And this is our memento, our appreciation, and of course, a token of certificate. We really appreciate your time. We really appreciate your knowledge that you have shared with our student, and they have all gained from it. Thank you very much.
Thank you.
So we come to an end of this particular session, and now we will be proceeding with the student presentation. Madam, if you have time, you can just listen, but you have lectured all through, you can just rejoin at a later time.
Thank you so much.
You can always listen to them because I know that you will also like the way, the enthusiasm in a young mind. I always do that. I like to inculcate this enthusiasm in the young mind so you can also see that how they are presenting. Thank you.
Sure. Thank you.
After an attention-drawing lecture of the guest speaker, we now move on to the technical sessions of the day. We begin with the UG presentations. The judges for this event are Dr. Rithi Mojumdar, Assistant Professor, and Dr. Kasturi Sharkar, Assistant Professor. The first speakers are Advija Banerjee and myself, Kritika Shaha.
A very good evening to the respected judges, my professors, seniors, juniors, and my fellow friends. Myself, Audrija Banerjee and Kritika Shaha are going to present on the paper titled The Gut Microbiome Alterations and Inflammation Driven Pathogenesis of Alzheimer's Disease. In fact, I would like to start with a very brief introduction of what is Alzheimer's disease. It is a neurodegenerative disease that causes irreversible progressive brain disorder, destroying the memory, thinking skills, and the ability to carry out the simple tasks. In fact, it is the most common cause of dementia among the older adults, generally above the age of 65 years. While the early symptoms include difficulty remembering the recent events, the later symptoms turn out to be drastic, including difficulty with language, disorientation, mood swings, motivational loss, and the behavioral issues. The disease is named after Dr. Alois Alzheimer, who first identified the changes in the brain tissue of an old woman who died because of that particular brain disorder, later which we know as the Alzheimer's disease. Over the years, there has been many hypotheses that tried to explain the cause of this disease, some being the cholinergic hypothesis, the tau propagation hypothesis, amyloid cascade hypothesis, the mitochondrial cascade hypothesis, oxidative stress hypothesis, and the Osaka mutation. However, with the researches going on over this, the present hypothesis, that is the inflammatory infectious hypothesis, which is the main focus of this research paper, will be further explained and taken up by Kritika. Kritika, over to you.
Thank you, Audrija. Can you hear me?
Yes.
Thank you, Audrija. We'll first explain three important terms. The first term is gut microbiota. It, as defined by molecular biologist Joshua Lederberg, the gut microbiome is the totality of microorganisms, that is bacteria, virus, protozoa, and fungus, and other collective genetic material present in the gastrointestinal tract. The bacterial phyla included are Firmicutes and Bacteroidetes. The next term is dysbiosis. It refers to the imbalance between the types of organisms present in a person's natural microflora, especially of the gut, thought to contribute to a range of conditions of ill health. A travel from the developed world to a developing world has shown that there is a twofold increase in Bacteroidetes to Firmicutes ratio in an individual, which reversed upon return. Common human actions and experiences like high-fat diet and antibiotics can easily alter the ratio of microorganisms in the gut. The third and the final term is the blood-brain barrier. The blood-brain barrier is a network of blood vessels and tissue that is made up of closely spaced cells and helps keep harmful substances from reaching the brain. Next topic, development of Alzheimer's disease. The intestinal microflora, which makes up the gut microbiome axis, actively takes part in the bidirectional communication between the gut and the brain. Astonishingly, the intestinal microflora has been termed as second brain. It is quite amazing to know that the intestine harbors about 100 trillion microbes, that is roughly about 95% of the entire population of microbes of the body. It provides a two-way communication between the gut and the brain through immunological, neural, and hormonal signals. Now, bacteria in the gut release a wide variety of neuroactive molecules, metabolites, etc. Interestingly, for a perfect state of symbiosis and commensalism, the different substances released perform a coordinating function. An example put here could be good. Butyrate and propionate are short-chain fatty acids released by gut microbes. On one hand, butyrate affects cholinergic neurons of the gut nervous system, causing increased motility, while propionate will decrease motility and increase secretions. But dysbiosis, which can occur due to aging and other reasons, destroys this balance. As a result, the secretions decrease the tightness of the blood-brain barrier, causing the intestinal microbiome to come in contact with the submucosal lymphoid tissue. The microbial exudates which easily reach the brain through the impaired blood-brain barrier include LPS and amyloids. This leads to neuroinflammation. Chronic neuroinflammation leads to neurodegeneration. Possibly, modulation of gut microbiota as well as therapeutic intervention against gut microbiota dysbiosis will become a new approach to treatment of Alzheimer's disease, just as fecal microbiota transplantation is used to treat infections caused by Clostridium difficile. New research on AD. New research has proved that brain tissues harbor nematode larval and adult worms which secrete microbial proteins that affect amyloid formation. But again, immunoregulatory functions of worms can help re-establish the balance of the gut microbiome and thus form a healthy microflora. The change in gut microbiota in nematode infection may happen because of secretion of antimicrobial components by the parasite which actively modulate the gut microbiome. It has been seen that Helicmos moes polygurus prevents the growth of Bacteroides vulgates against intestinal inflammation in mice. This is an excellent example of type 2 immune response, which leads to expansion of intestinal bacteria like Clostridial species. Thus, the multidimensional relationships between the host body and the gut microbiota parasites result in the formation of a complex ecosystem where alterations in one of these components determine a counter response in others. Over to you, Advija.
Thank you, Kritika. So it's time we have come to the end of our conclusion. I would like to conclude by saying that this paper tries to highlight the important roles of the peripheral infections and the intestinal microflora on the physiological function of microbiome intestine brain axis. However, incomplete understanding of the cause of this disease made it impossible to find an effective treatment against this disease. But from this paper, we understand that including good probiotics in the diet increases the good microbes in the gut, thus reducing the risk of Alzheimer's in the future. Thank you for both of us.
Thank you, both of you, for your presentation. I think, yes, ma'am, you want to ask anything?
Thank you, sir.
Yes, I have a question.
Yes, ma'am.
Yes, ma'am.
Yes, you talked about these viruses, right? So,
Yes, ma'am.
can you mention some of the factors that can lead to these viruses?
Yes, dysbiosis is basically the imbalance in the gut microflora. It can occur due to infections like enteric infections when a part of the gut microflora gets disturbed and has to be restored. It can occur due to a change in diet. It can occur due to antibiotic consumption.
Aging is
It
also a
can,
factor. Aging is
yes,
also a
right,
factor.
right, right. Aging is also a factor behind dysbiosis.
Yes, nice. Riddhi sir, you can ask them if you have any question.
I have no questions to ask. In that case, I think thank you for your presentation. We will move to the next presenters. Thank you.
Thank you. Thank you, sir.
Thank you, sir. The next presenters are Ishan Bose and Liana Mukherjee.
Please go ahead and start.
A very good evening to the respected teachers, the respected judges, my dear friends, and the audience members. Today we, Liana Mukherjee and Ishan Bose, are going to present a paper entitled Hypertonic Glucose Inhibits Growth and Attenuates Virulence Factors of Multi-Drug Resistant Pseudomonas aeruginosa. Pseudomonas aeruginosa is a gram-negative pathogen which can cause life-threatening infections in immunocompromised patients. Due to extensive use of antibiotics, an evolutionary pressure has been created on P. aeruginosa, which has led to high levels of multiple drug resistance. The pathogenicity of P. aeruginosa is influenced by several factors, such as biofilm formation, motility, and virulence factors such as pyocyanin and elastase. These factors are regulated by quorum sensing. Quorum sensing, or QS, is a cell density dependent regulation of gene expression via extracellular signals. Bacteria produce small diffusible signals termed autoinducers, and when these signals reach a critical threshold concentration, the targeted QS genes are activated or repressed. The three QS systems of P. aeruginosa are termed as LAS, RHL, and PQS. LSI, RHLI, and PQSA biosynthesize signal molecules such as N3-oxododecanoyl L-homoserine lactone, N-butyryl homoserine lactone, and Pseudomonas quinolone signal respectively. LSR, RHLR, and PQSR respectively are the corresponding receptors for the signal molecules. Genes responsible for the pathogenic phenotypes of P. aeruginosa can be activated by specific autoinducers binding to the receptors. Therefore, P. aeruginosa infections can be treated by using anti-QS strategies as a potential approach. The expression of these QS systems have been found to be sensitive to environmental conditions. In this report, the activities of these quorum sensing systems have been examined under hypertonic glucose conditions. The objectives of this study are to analyze the effects of hypertonic glucose on multi-drug resistant Pseudomonas aeruginosa strains isolated from diabetic foot infections, and to investigate a novel approach to control P. aeruginosa related chronic wound infections. The methods are as follows. At the first affiliated hospital of Wenzhou Medical University in China, P. aeruginosa strain PA01 and 4 other multi-drug resistant P. aeruginosa strains were isolated from different diabetic foot ulcers from patients and studied. All the strains were cultured in Luria bertani medium at 37 degrees Celsius. It was followed by the determination of the minimum inhibitory concentration values of glucose, or MIC. The MIC is the lowest concentration of a chemical or a drug which prevents visible growth of the bacteria. This was followed by the determination of the growth curve assay. Several assays were conducted in the presence of hypertonic glucose to determine its effects on P. aeruginosa. The biofilm forming capacity of P. aeruginosa strains was determined using crystal violet method. It has been found that the MICs for biofilm embedded bacteria differ from their planktonic counterparts. The swimming motility assay was then performed. It is seen that flagella contribute to virulence through chemotaxis, adhesion to, and invasion of host surfaces. Pyocyanin assay was performed to examine its production. Pyocyanin interferes with many mammalian cell functions, including cell respiration, ciliary beating, epidermal cell growth, and calcium homeostasis. The elastrolytic activity of P. aeruginosa was determined using elastin Congo red as the substrate. The elastase enzyme produced by P. aeruginosa increases the permeability of airway epithelial cells owing to the disruption of tight junctions, hence it plays a key role in virulence. Then, Galeria melonella killing assays were performed. 8 larvae were infected with P. aeruginosa. Glucose was then injected into the last right leg proleg. The rapidity and extent of mortality of G. melonella was the primary outcome for the insect model. Finally, QRT-PCR was used to evaluate the effects of hypertonic glucose on the expression levels of P. aeruginosa major QS circuit genes. Now I shall pass over to Ishan, who will discuss the results of this report.
Good evening to all. I'm Ishan and I shall now discuss the results of the experiment. Firstly, it was seen that glucose inhibited the growth of all P. aeruginosa strains at a concentration of 300 mg per ml. This is the minimum inhibitory concentration. Also, in the G. melonella larva infection model discussed earlier by Liana, following the administration of 200 mg per ml of glucose, the survival rates of larvae infected by the P. aeruginosa isolates were enhanced. Here in this OD at 600 nanometer versus time graph, different graphs are plotted at different concentrations of glucose. At a concentration of at least 50 mg per ml, glucose showed a concentration-dependent inhibitory effect on the growth of all pyrogenosa strains. It is seen that the growth rate decreases with an increase in glucose concentration. Here in this OD at 595 nanometer versus glucose concentration graph, at a concentration of 50 milligram per ml, glucose caused a 50% reduction in biofilm forming capacity of all pyrogenosa strains. A concentration-dependent inhibitory effect of hypertonic glucose on the swimming motility of all pyrogenosa strains was also observed in this mobility diameter versus glucose concentration graph. As we see on the picture on the left, the sample is inoculated at the center of the plate. After incubation, after incubation, it diffuses or moves away from the center. We can see that the mobility decreases with an increase in glucose concentration. These are graphs, these are different graphs showing the percent production of pyocyanine and elastase versus glucose concentration. It is seen that at least 80% reduction in the production of pyocyanine and elastase was observed at the glucose concentration of 100 milligram per ml. Hypertonic glucose treatment significantly reduced the expression of LSI, LSR, RHLI, and RHLR genes. The virulence factors of pyrogenosa are primarily encoded by these genes. The LSI and RHLI genes are required for the synthesis of the quorum sensing signals, which are capable of binding to transcriptional regulators LSR and RHLR respectively. LSR and RHLR interacting with the corresponding signals can trigger the release of pyocyanine, elastase, and other virulence factors. Therefore, the significantly decreased expression of QS-regulated genes correlated with a decrease in virulence factor production. Now, Pseudomonas aeruginosa is much more dangerous to certain populations, including those who have weak immune systems, the elderly, and those who have been hospitalized for long periods of time. People with cystic fibrosis and with AIDS frequently die from infections created by this bacteria. Extensive use of antibiotics has created an evolutionary pressure on this bacterium, due to which there is high levels of multiple drug resistance. Strategies that minimize the probability for emergence of antibiotic resistance are needed to combat this pathogen. This study is the first of its kind to demonstrate the inhibitory effects of hypertonic glucose on Pseudomonas aeruginosa. Hypertonic glucose was shown to inhibit the growth and biofilm formation and swimming motility of pyrogenosa. Virulence factors were also attenuated, which was correlated with a reduced expression of genes involved in quorum sensing. As a concluding note, I would like to say that more such studies which investigate the hypertonic glucose and wound infection management should be conducted. These are the references used for our presentation. Thank you.
Very nice presentation by both of you. I have one small question. Now, you showed a plate assay where you were talking about the swimming motility. Now, I just asked you, is there any way they have ruled out that the microbes are not dying? And it's just to do with change in motility rate, not that death is also associated. How do you rule out that? How has it been ruled out? Can you enlighten us?
Sir, your voice is breaking.
I'm saying there is a swimming motility assay. So is there any way you can make out that there is a less in movement and not that that's because the bacteria are dying?
Sir, I could not get you.
You
Your
got my
voice is
question?
cracking. No, sir, your voice is cracking.
Oh.
Ritu sir, we could not hear you properly. Ritu sir?
Can any of you hear me now?
No, sir.
No, sir.
Yes. So my question is, how do you rule out that the swimming assay is high level of glucose just affect the motility and it does not cause the death of the bacteria? You got my question?
We can't hear you, sir.
Sorry to interrupt, sir, but your voice is breaking, sir. Can you please use the chat box then? Our MC will read out the question.
I think yes, ma'am. Please take over.
what is the reason of high concentration of glucose being toxic for pre-aeruginosa?
Ma'am, this exact mechanism, how it is associated with reduction in bacterial virulence, this mechanism is still under study because this is a first research paper which has investigated the effects of hypertonic glucose on P. aeruginosa. So the researchers are still investigating the mechanism.
Hello, can you hear me now?
Oh, sir.
No, sir.
No, sir.
So my question is,
And what concentration of glucose did they use for the study?
Ma'am, it has to be at it is hypertonic glucose, so it has to be at a concentration of 5% or higher.
5%.
But the different, it has to be at a concentration of 5% or higher, but the different kinds of, such as, for example, the growth curve assay, it was showing that it was being inhibited at 300 mg per ml. So it varied according to the type of experiment that was being
Varies
performed.
according to the experiment.
thank you.
Okay, so thank you.
Thank you, ma'am.
Thank you, ma'am.
The next presenters are Pallab Ghosh and Shoni Chattopadhyay.
Am I audible?
Yes, carry on.
Yes, you are.
A very good evening to the respected judges and all the viewers. What is atherosclerosis? This term is very much common to all the science pursuers, but our own gut microbiome influencing it. Let's see the facts. Today, myself, Pallab Ghosh, and my partner Shohini Chattopadhyay would present a paper on non-lethal inhibition of gut microbial trimethylamine production for treating atherosclerosis. A brief introduction of the actual problem. We, the human beings, take a lot of fat-rich food, which is rich in phosphatidylcholine. On ingestion, it breaks down into choline. We have a huge reservoir of gut microbes like Proteus penneri, Proteus mirabilis, which secretes an enzyme TMA-lyase. This TMA-lyase acts over choline and forms TMA or trimethylamine. It is transported to the liver and oxidized under the action of the liver enzyme flavin monooxygenase to form TMAO, which is the N-oxide form of TMA. And if the concentration of TMAO increases in the blood, it increases the risk for atherosclerosis. Now, what is atherosclerosis? It is basically a cardiometabolic disorder in which the cholesterol plugs, the lesions, they are deposited over the blood vessels, which disrupts the blood flow to the heart, and it can cause the risk for heart attacks. How to reduce this risk? First of all, we have to reduce the level of TMA and TMAO in the blood for checking atherosclerosis. For this, the scientifically proven way is we have to choose an analogous substrate. that is DMB or dimethylbutanol, which has a lower Km value and hence higher affinity towards this particular enzyme, TMA-lyase. So it will block the active site of this enzyme and hence choline cannot bind to it. Now, if TMA is not produced, because DMB is binding with TMA-lyase, hence it will decrease the risk for atherosclerosis. So if DMB and choline, they are both present in the diet, it will reduce the TMA level, which will also reduce the TMAO level in the blood, and it will decrease the risk for atherosclerosis. Now I will like to pass over to Shohini for further discussions. Thank you.
Thank you, Paulo. Now the question arises as to what is non-lethal inhibition and why it is so important. Non-lethal inhibition that is being done here is that the microbes are not being killed, but the TMA-lyase enzyme which is being produced by the microbes are being blocked. So this non-lethal inhibition is important instead of the administration of antibiotics is because if the antibiotics would be used to kill these gut microbes, there will be a lot of selection pressure and it will lead to the microbes mutating among themselves and it will make them drug resistant, which will be very difficult to control at a later stage. Secondly, the normal microflora, the beneficial microbes present in our gut will also be affected and killed due to the administration of antibiotics. And therefore, it is better to not kill these microbes and have a non-lethal inhibition approach. Now let us look at some of the experiments which were done for this approach in vitro as well as in vivo on laboratory mice. And it is presently going through human trial. In vitro experiments. The two in vitro experiments which were done were as follows. Firstly, the CUT-CD gene, that is a particular gene of the gut microbes, which is responsible for producing the enzyme TMA-lyase, was taken in vitro, and the effect of dimethylbutanol, that is the analogous substrate, was demonstrated. The results clearly proved that when DMB was given along with choline in the diet, there was much less TMA produced than only when choline is administered, hence proving that DMB reduces the TMA level, and in vivo it also mentions that it will reduce the TMAO level. The second experiment was done on the entire microbial cells as a whole, this time to prove that DMB not only reduces the TMA production, but also without killing the microbial cell. That is, its non-lethal action is verified. Moving on to the in vivo experiments on mice. In vivo experiments were performed on two sets of mice. Firstly, on one set which were given DMB-rich diet, and another set which were given choline-rich diet. The mice which were given DMB-rich diet showed much less presence of TMAO in their blood, as was produced in the liver, as compared to those which were given choline diet. Lastly, in vivo experiments were performed to prove that the TMAO level of blood is directly proportional to foam cell and lesion formation and thus directly proportional to the risk of atherosclerosis. As we can see in this chart given here, that when the percentage of TMAO or the amount of TMAO in the blood increases, the atherosclerotic lesions shown in the form of red patches also increases as against the control where TMAO is much less and the lesions can also be found to be much less. Now let us look at the results in the graphical form. In figure 8a, we can see the difference in the level of TMAO in blood when only choline is incorporated and when DMB is also incorporated. As we can see that the amount of TMAO that is formed when choline minus DMB, that is without DMB, is given is much greater than when choline plus DMB, that is in the presence of DMB, is given. The same trend is seen not only for choline diet but also for another diet, carnitine, and not only for male mice but also seen in case of female mice. In figure 8b, we can see the trends in formation of the foam cells and aortic lesions when choline is incorporated and when DMB is incorporated in the diet. We can see clearly the percentage of foam cells are much greater when only choline is administered versus when choline plus DMB is given. The same trend is seen for aortic lesions also. When choline is administered, the level of aortic lesion is greater than that when choline plus DMB is administered. It can also be seen through this illustration where the red patches indicate these aortic lesions, which are much greater when choline is given and much less when choline plus DMB is given, thus proving that our experiments have been done successfully and DMB can be used as an analogous substrate. Now I would pass over to Paul Loeb to conclude the presentation.
Thank you, Shohini. In the conclusion, the whole pathway we have taken it from the paper. Here, choline to TMA is blocked by DMB, and this approach has been proven as a potential therapeutic approach for the prevention of atherosclerosis. Not only atherosclerosis, in near future, various other cardiometabolic disorders can be cured by this particular pathway. And this idea of curing the atherosclerotic lesions through this pathway is under the human clinical trial. It has already passed the first phase by a US-based biotech company. Here are the references from which we have collected our informations. And lastly, I would like to thank respected Father Principal and all the professors of our department for giving us this opportunity to present in front of the stalwarts. And I would also like to thank our friends, family, batchmates, our seniors for helping us. Above all, we are really thankful to the Almighty for this prestigious opportunity. Thank you. Thanks a lot. Have a nice day.
Thanks to both of you. S-
Okay, maybe you said, but I missed it. What was the dose and the duration of those molecules during the treatment or during the experiment? I mean, that choline and TMD.
Ma'am, the choline is given in the diet of the mice. The exact concentration is not limited, but it is the mice are actually given the chow diet, and in the chow diet, the choline is mixed with the chow diet at a percentage that might vary from the size of the mice and their different strains, different types of mice actually.
But there should be an exact value, right? As they are doing an experiment on animal system, animal model, it must be clearly spelled out. And for what duration? The animal studies?
Animal studies were done for ma'am, are you asking for the entire trial on mice or what
Yes.
is
Yes.
okay. The entire trial has taken about more than like 2 years for the entire research on mice.
That means changes in the disease condition are coming after 2 years of change in diet.
No, actually, the entire process of studying was done in about 2 years, where we could arrive at the conclusion. But in each mouse, as soon as the diet was administered, the effects were seen within a few months. But to arise at this particular conclusion, which we are concluding right now, it has taken more than a year. That is about 2 years to complete.
Okay, thank you.
Thank you, ma'am.
So we move to the next set of speakers.
The next presenters are Akanksha Shaw and Moinak Beda.
A very good evening to one and all present here. Today, we, Moinak, Beda, and myself, Akansha Shah, we are going to present a paper on microbial niche nexus sustaining wastewater treatment. Wastewater treatment plants, WWTPs, are important infrastructure to ensure the efficient management of wastewater. New concepts about future wastewater management have been always recovery simultaneously, the conventional discharging standards, and the emergence of new pollutants. Various types of micropollutants, including pesticides, pharmaceuticals, and endocrine disrupting chemicals, EDCs, have been continuously emerging in WWTP effluents. Since these chemicals are found in extremely low concentration, they are very difficult to be removed. Hence, it poses a challenge to the conventional WWTPs. This is where the concept of microbial niche nexus came into play. So, what exactly is microbial niche nexus? It is the tuning of microbial niches to accommodate diverse microbial communities for the efficient removal of known and unknown pollutants. Biological processes with the accommodation of microbial niche nexus are still and will be the key foundation for wastewater management. By proper regulation, suitable functional microorganisms can be selected and enriched in the wastewater treatment plants to fulfill the removal of various types of pollutants and recovery of energy. Thus, in this way, we can achieve the sustainable development of the nexus system. Having known the background of microbial niche nexus, I'd now like Moina to highlight the approaches for the efficient recovery and retrieval of energy. Over to you, Moina.
Thank you, Akansha. As my friend Akansha already said, our objective is not only to treat wastewater, but also to recover energy efficiently at the same time. It has been reported that presence of sulfate inhibits methanogenesis. The goal is to produce methane efficiently in sulfate-rich environment. This can be achieved by tuning the niche in such a way so that both sulfate-reducing bacteria and methanogens can do their work efficiently. So, how do we do it? Research showed that when magnetite is added to a sulfur-containing reactor with low methanogenic efficiency, it re-enriched the centropic partners like geobacter, sulfur reducents, and methanosarcina, and boosted the production of methane. It has also been proved that supplementation of magnetite in rice paddy fields significantly increased methane production. So how does this work? Earlier, it was known that interspecies electron transfer occurs via hydrogen and formate being the electron carrier in centropic methanogenesis. But recently, it was discovered that some microbes, like the methanosarcina, exhibit direct interspecies electron transfer or DIET. This method of direct cell-to-cell electron transfer is enhanced by the addition of magnetite or carbon nanotubes, which acts as a conductive material for efficient electron transfer. The centropic partner Geobacter sulfur reducens, which also has DIET ability, that is direct interspecies electron transfer, can be further enriched by adding brewery wastewater, since it consumes ethanol as an organic substrate and plays an important role in methane production. For the proper infrastructure design, along with enrichment of specific microorganisms, the substrate-based niche tuning should also be taken into consideration. From an evolutionary viewpoint, there are two types of microbes, R strategist and K strategist microbes. R strategist microbes grow better in high substrate concentration and can grow rapidly, but cannot withstand sustained competition. Whereas K strategists grow in substrate limiting conditions, but have better survivability. In a plug flow reactor system, R strategist will grow better at the entrance where the substrate concentration will be high, whereas the K strategist will grow better at the rear part of the reactor where the substrate concentration will be low, since most of the contaminants will already be degraded by the R strategist and only the micropollutants will remain. In addition to this ability of growing in oligotrophic conditions, case strategists may have high affinity for micropollutants if they possess relevant genes and enzymes. Based on this theory, systems with high substrate gradient to provide specialized niche for both R and K strategies will ensure efficient removal of all kinds of pollutants, be it conventional or emerging micropollutants. Now, Akansha will take over and explain the different strategies for the removal of emerging pollutants. Over to you.
As we know, cysteine is a biothiol and can be easily oxidized to form disulfide it stabilizes nanoparticles by forming a bond on the surface, which is formed nanoparticles. Say for the see that cysteine has the ability to mitigate the nanoparticle toxicity. To understand the role of COMAMOX, that is complete ammonia oxidizer, in micropollutant biotransformation, the biotransformation capability of Nitrospira inopinata, the only COMAMOX isolate, was investigated. It was found that the bacteria could degrade like more distinctively, carbon diamines of exclusively biotransformed by N transformation carbon as their degrade pollutant nitrified environment. As we come towards the end of this presentation, I would now like to conclude microbial communities to be explored and utilized for solving new challenges, including emerging compounds removal. All these can be achieved through the optimization of microbial niches to enrich diverse microorganisms in the present wastewater treatment plants, besides to build new infrastructure. Investigating the metabolic kinetics, diversity, and microbial interactions of new microorganisms is crucial for developing novel wastewater treatment technologies. Thus, to achieve this purpose, it is essential to further explore the unrevealed biological processes or function. Interdisciplinary
These are the reference we used for this presentation. Thank you.
Thank you.
Yeah, thank you, both of you. I have a small question. I'm inquisitive about it. So you have talked about geobacter and you have talked about nitrospira and you have talked about the R and the Ks. So is there any correlation? Means is how can I put geobacter in which category? R category or K category? Moina, can you go ahead?
Sir, can you please be a little louder?
There are the geobacter and the nitrospora you have spoken about. So
yes,
of these two, R and K you have also spoken about. So
yes, sir.
geobacter fitting R or it's K?
So nitrospira is reported to be a K strategist microbe, and
Okay.
geobacter is an R strategist.
So in the same reactor, I can have both of them, or the answer is no.
Sir?
So in the same reactor, can I have both these microbes? Or
Sir,
Yes, sir,
this
we
is
can have both
this is totally based on a theory actually.
the R and K.
Yes. If we include both of them, that will ensure the removal of both the micropollutants as well
So
as the
when
conventional
the substrate
pollutants.
concentration is high, we can use the R strategist microbes, and when when there's limiting like substrate concentration, then we can use the K strategists because like they can grow in the limiting conditions.
yeah, that's a very nice answer. But what I'm interested in, is there any actual practical examples of using such things in the same reactor?
No, till now there is nothing like that. Actually, this is totally based on a theory. If we can incorporate both R and K strategist, then it will ensure the removal of both the micropollutants and the conventional pollutants.
Okay, thank you, thank you.
Thank you, sir.
Over to case man, if she wants.
Thank you, sir.
Thank you.
Thank you, ma'am.
I think we move to
Thank
the
you,
next
ma'am.
question. Yes, thank you both.
Thank you, Kancha and Moinak. The next participants are Tiash Shaha and Anika Khan.
Good, good evening to one and all present here. Today I, Anika Khan, and my co-presenter Tia Shah would like to speak about synthesis of bacterial amyloid curly in vivo contributes to joint inflammation in Salmonella typhimurium infection. Next slide, please. Reactive arthritis, we all know, is an autoimmune disorder which occurs following gastrointestinal infection with invasive enteric pathogens such as Salmonella enteric. Curly, which is an extracellular bacterial amyloid with cross beta sheet structure, can trigger inflammatory responses by stimulating pattern recognition receptors. Curly are highly aggregated, thin amyloid fibers expressed on the surface of enteric bacterial cells. These fibers usually range from 4 to 10 nanometer in width and have a rich beta sheet structure in which these beta sheet strands are oriented perpendicular to the axis of the fiber. This cross beta sheet structure is characteristic of amyloids, including the majority of proteins associated with human amyloid diseases. Next, please. Salmonella enterica sarovar typhimurium is a common non-typhoidal salmonella species which causes gastroenteritis in immunocompetent individuals. Approximately 5% of patients develop an autoimmune condition known as reactive arthritis following gastrointestinal infection with S. typhimurium. Some patients remain symptomatic for 5 years or longer. S. typhimurium also successfully colonizes multiple surfaces in the environment and cycles between the host and the environment. During the environmental phase of its life cycle, S. typhimurium forms multicellular community called biofilms. Biofilms are structures which involve a thick extracellular matrix composed of curly, cellulose, BAPA, and extracellular DNA, which has been shown to protect bacteria from various environmental insults, including chemicals, osmotic stress, oxidative stress, and so on. The ability of NTS to form biofilms is predicted to be a conserved strategy for increased persistence and survival in non-host environments, which would increase the likelihood of transmission to a new host. Curly biosynthesis is controlled by type 8 secretion system encoded by two divergently transcribed operons, the CSG-BAC and the CSG-DEFG. Routine curly production by Salmonella in vitro occurs at temperatures lower than 30 degrees centigrade, suggesting that fiber synthesis is limited to environmental conditions. The first biochemical evidence that these fibers are produced in the GI tract of mice after oral infection, which is the natural route for Salmonella infection, is presented in this paper. Uh, Curly amyloid, which is produced by bacteria, provides a supportive framework for biofilms, just like the infrastructure of any apartment building. The curly amyloids are produced in the cecum and colon of mice after natural oral infection in both acute and chronic infection models. Next, please. Production Production of curly was associated with an increase in the double-stranded DNA autoantibodies and joint inflammation in infected mice. The negative impact on the host appeared to be dependent on the invasive systemic exposure of curly to immune cells. It is hypothesized that synthesis of leads to known complications of enteric infections. In this study, it is shown by the scientists that S. typhimurium produces de novo curly in the murine GI tract following the oral infection. That expression of curly leads to elevated level of autoantibodies and inflammation in joints, which are both hallmarks of human reactive arthritis. Next. The negative impacts of curly appear to be correlated with cellular invasion, access of curly to the systemic tissues surrounding the intestine. This study was published online on July 9 in the journal PLOS Pathogens. The research was carried out in collaboration with Dr. Kavla Tukul, Dr. Aaron P. White, and his associates at the Vaccine and Infectious
Disease Organization in Canada. Now I would like to pass on to my co-presenter who would speak about the various results of this experiment. Over to you.
Detection of curly in the intestinal tract of mice infected with Salmonella typhimurium. Streptomycin pre-treated mice were orally infected with Salmonella typhimurium grown so that the curly were not present in the inoculum. At 4 to 6 days after inoculation, mice were successfully infected as measured by colony counts from the internal organs in the faeces. Tissue embedding and sectioning were performed and small bacterial clusters or microcolonies were visible within the cecum. Now, in this thing, we can see figure A and B. Now, multicolored immunohistochemistry staining revealed that these rod-shaped bacterial cells were salmonella and were producing curly. In figure B, we can see salmonella were found exclusively within the luminal compartment of the cecum as defined by ZO1 staining on the apical surface of the epithelium. Control experiments with non-immune rabbit serum, figure C and D, did not show any unspecific staining. Dense concentration of Salmonella typhimurium showing positive staining for curly were detected in the cecum, figure F and I. Now in figure G and J, we can see in the colon, the Salmonella typhimurium were detected more tightly packed, had the most intense curly staining and appeared to be in the lumen. And finally, in figure E and H, we can see in contrast S type negative for curly production in the small intestine and was sporadically spread out over the 30 centimeter length of the intestine. S typhimurium were detected in the liver but were not recognized by anti-curly immune serum. Now, oral infection with wild type S typhimurium leads to the generation of anti-double-stranded DNA autoantibodies. Now, groups of mice were orally infected with 10 to the power 8 colony-forming units of S typhimurium or its isogenic curly mutant. Figure A, fecal pellets were collected on the days shown after infection and the levels of S typhimurium were determined. Figure B, spleen and liver were collected at the experiment endpoint, 42 days, and bacteria were enumerated. Figure C, STS page gels were loaded with a GST or GST-CHG-AR1 to 5 fusion protein, sera from mice infected with S. typhimurium or its isogenic curly mutant for 42 days were used as primary antibodies to detect CSGA production. Now, figure D, ELISA was used to quantify the levels of IgG antibodies specific for CSGA in 42-day-old serum from mice infected with Salmonella typhimurium or the isogenic curly mutant. The absorbance values shown represent with Salmonella typhimurium or the isogenic curly mutant. Now, curly expression leads to autoimmunity and inflammation of joints. Oral infection of mice with H. typhimurium leads to the generation of anti-DS DNA autoantibodies and joint inflammation. Now in figure A, we can see the mean levels of S. typhimurium in CFU. Standard error was determined in fecal pellets collected on days 1, 3, 7, 14, 21, and 28 post-infection. Figure B, at day 4 post-infection, it was analyzed light production in the intestinal tract, spleen, and liver from mice infected with S. typhimurium, CHG luciferus reporter strain. Figure C, the mean levels of anti-DSDN autoantibodies in mouse serum as quantified by ELISA. Knife mouse serum was used as a negative control. Figure D, the level of inflammation in knee joints from S. typhimurium infected mice was scored by a pathologist. And finally, figure E, the scoring was applied to tissue section prepared from each infected mouse with the representative images shown in. Arrows denote the synoviocyte infiltration. Now we come to the significance. It is significant because of the immune impacts on the host. It is shown that the curly cause an increase in the autoimmunity and inflammation in the knee joints of the infected mice. Reactive arthritis is a known autoimmune complication after enteric infection, and the results indicate the presence of curly in the gut provides a novel linchpin of pathogenesis. As curly or curly-like amyloids are also produced by the commensal bacteria, it is possible that the unintended release of amyloids produced by the microbiota could trigger similar autoimmune reactions. Now we come to the conclusion. The discovery that S. typhimurium produced curly in the murine large intestine brings together years of research on differing aspects of salmonella life cycle and reinforces the connection between persistence and virulence. Thank you so much.
Thank you, both of you. I have a small question for Tiash. So Tiash, so the slide where you showed all the graphs and the tissue sections, what is the take home of the slide? So what do we understand from that experiment? In few words, what is the take home?
Sir, can you be a little louder? I cannot hear you, sir.
So Tiash, you have shown the slide where there were graphs and there was a tissue section. Okay. Before
Yes, sir.
that, you have showed the slide where there were lots of fluorescence imaging. So I'm not talking of that slide. I'm talking of the second slide. So what is the take home of that slide where there were tissue sections and the graphs?
Sir, actually, see, this paper was actually published in July 9, so it was a very recent paper, and so there is only one paper published till date. So the experiments were performed, and from the graphs we can see that the mice were infected with Salmonella typhimurium, and from their tissue section it is shown that how that the disease progression in mice occurs, and subsequently what would happen if the Salmonella typhimurium actually infects a normal human being. So that those are the results obtained from mice, and subsequently those are the results we can predict if it occurs in a human being.
Hello. So, how did you extrapolate it to human being?
So this is not tried in human beings now. It is tried in mice. So scientists have said that there are possibilities that these symptoms might happen in human beings as well.
Okay, okay, okay. Thank you. Thanks to both of you. Okay.
Thank you, sir.
So actually, this experiment was performed in mice, and the generation of those autoantibodies and the inflammation of joints, which are like the hallmarks of human reactive arthritis. So this was seen in mice. So it is assumed that like this is the case for humans too, and further research is going on this. Like nothing is like guaranteed for humans, but for mice it's confirmed, like how the things happen.
Yes, ma'am, you want to ask anything?
Yes, I have a question. Uh, Carly, as you said, it is a beta amyloid, right? Carly is the name of the aggregates.
Yes, hello. Yes,
Hello,
ma'am.
yes. Yes, beta amyloids, as we know that they are protein aggregates. When hydrophobic proteins or proteins with hydrophobic residues, they interact with each other, they form sponge-like structure, and those structures are basically called
Yes,
beta
ma'am.
amyloid, right?
Yes, ma'am.
What is Carly basically? It is the name of the beta amyloids formed in the gut, or what is the basic protein? Or what are the basic proteins which are formed?
Ma'am, curly are like tight or tight pack of beta strands, which like gives high stability and physical robust to the filaments.
So Carly is the protein, and
Yes,
many
ma'am.
such Carly proteins are forming aggregate. Right?
Yes, ma'am. It causes aggregates.
So the aggregates must be irregular in shape and molecular weight, right? They can have different varying molecular weight. How do they
Ma'am.
enter into the blood circulation from the?
Ma'am, in the paper it said that when the problem starts when this curly amyloids they escape the intestine and enters the blood, and then the symptoms were shown, like the generation of autoantibodies and the inflammation in joints, like as in the graph it is showed. So
Yes, my question was, what is the entry point of these amyloids? The endothelial cells, they take up the amyloids, Carly, or uh, they enter into the blood circulation through the immune cells. Okay, okay, thank you.
ma'am,
Yes.
they enter to the immune cells, like
Thank you to both of you. We move to the next set of speakers.
Thank you, Tiash and Anika. The next presenters are Sanjana Lahiri and Shumokshu.
Very good evening to KS ma'am, RM sir, and everyone else watching on today. We welcome you to the presentation of our the paper titled "Evaluating the Ecological Resilient Driven Performance of a Tropical Waste Stabilization Pond System using ecological signature of biological integrity. So as we can see from this slide, the research we are presenting today holds a special relevance and significance in the contemporary context with global warming, climate change, forest fires, oil spills, and a plethora of other anthropogenic ecological disturbances reaching a peak in both frequency and intensity. Uh, we think that ecological balance and resilience will play the most important role in securing a sustainable future. Now, ecosystems are nuanced and dynamic entities that are affected by numerous components, factors, and interactions. And every single one of these interactions have multifaceted impacts. Therefore, the regulation of such a complex entity must be done through careful scientific instruction. In order to achieve this Herculean task, there is a system that we are talking about today, and that system is that of the keystone structuring process that acts as a skeletal framework to maintain ecological balance. Now, as a part of this keystone system structuring process, we see that there are trophic structures, stability, productivity, diversity, or both qualitative and quantitative diversity, species imposition, as well as something we call biogeochemistry, which are talking about the various nutrient cycles present in the ecosystem. Now, along with the keystone structuring process, we also consider and incorporate something called species redundancy behavior to ensure that a species does not grow uncontrollably and unwantedly by flourishing, which will lead to disrupting the ecological balance of that system. Now, through these processes, we aim to achieve ecological resilience, which consists of three primary aspects. That is holism, that is the all totality; buffer, which allows a margin of error for us in maintaining the homeostasis within the system; and of course, the stability present. Now, all of these factors and this keystone structuring process are then extrapolated onto a temporal scale, and then what is being done is making sure that the balance is not only present currently, but restoration efforts can always make the system sustainable in the future. Now, here in the next slide, we see a treatment. We see that the primary treated sewage is going through to a waste stabilization pond. Now, a waste stabilization pond can be thought of as a tertiary treatment system that mimics nature's biological processes, providing ideal conditions for biochemical reactions. As shown in the diagram as well, it has an upper aerobic layer, which is an active zone with bacteria, algae, organic matter, inorganic matter, and the like. It is also exposed to sunlight and oxygen. And the lower layer is like an anaerobic detritus where heavier particles sink and settle down. And here somewhat some bottom feeding organisms which are extremely tolerant can also be found sometimes. Now, this combination of organisms that regulate the ecosystem by achieving ecological resilience, as we say, uh, they achieve this through the various metabolic activities of their own, and they are called the bacteria algae heterotroph complex. They are in fact the driving force behind this process and can be thought of as the tool which helps us get to our aim, which is that of ecological resilience. Now, ecological signature can have many, the term can have many definitions, but what is important to note, like the important characteristics to note about it, is that they have certain unique, a unique point is there in any signature, like a real signature. There is a uniqueness in this particular combination, the bacteria algae heterotroph complex, and also like a signature, it validates something, it provides a validation to a particular task. So this, we are achieving this sort of stabilization through this ecological signature. Moving on now, this I will be moving on through this slide very quickly because there is no time. There are in fact certain gaps in the research, which is that there was a dearth of data available on such ponds, and especially to evaluate the resilient driven reclamation process and performance of domestic wastewater. Next, moving on, I'm extremely sorry, but this is such just a schematic diagram representing the plans of the treatment Scollani sewage treatment system. There is a screen chamber, then a grit chamber. Moving on to the splitting chamber, that there are, these are various processes of separation that takes place, and the main part that we are moving on to is this is how city sewage enters the plant. Now raw sewage enters the grid chamber, then through the various ponds. We come to the facultative pond, which is an aerobic condition. Maximum retention time of that is 6 to 7 days. Here we observe algal bloom, and sometimes we find bottom grazing fishes, as I mentioned earlier, like tilapia. When we move to the maturation ponds, we see that the water is becoming much more clearer. There is more dissolved oxygen, and when we reach the permissible limits of disposal of these things, we know that these can be in fact disposed into certain areas. So I will be moving on to giving over to Sanjana to take you through the rest of the presentation.
Hello, this is Sanjana. Good evening to everyone and my respected judges. Actually, Shomok, are you presenting in a full screen, because there's a black strip which is coming, so I can't see the entire slide.
You can go ahead now.
Yeah, okay, thank you. Yeah, so this is the results. So first we have the productivity of phytoplankton. Now we are considering the gross primary productivity. So it is being seen that it has gradually decreased from the facultative to the last maturation pond by across the swage effluent gradient by a percentage of 77, and similar has been seen in the case of net primary productivity and community respiration, where the percentage has decreased by 78 and 78.6 respectively. Now, astonishingly, in the ratio of photosynthesis is to respiration, there has been a gradual increase from the facultative pond to the last maturation pond. Now, this is why, because since in the facultative pond, the amount of nutrients is much higher, and even the bacterial count is much higher than the maturation pond. So the amount of photosynthesis and respiration is equally high, as a result of which their ratio is less. And in case of maturation pond, since both of the nutrients and bacterial counts are less, so the ratio is higher. Now, phytoplankton community was represented by altogether 28 species of microalgae, which were common in their distribution in facultative and maturation ponds, to their relativity abundance varied in across the effluent gradient. Next slide. Now, considering the nutrient cycling bacterial population dynamics, it is observed that the heterotrophic bacteria, ammonifying bacteria, phosphate solubilizing bacteria gradually decrease from the first facultative to the maturation point, while in the surface water, and similar observation has been seen in case of bottom water and surface sediment. Now, in groups of bacteria like cellulose decomposing bacteria, ammonifying oxidizing bacteria, and denitrifying bacteria, it has seen to increase from the maturation to the last maturation pond. Next slide. Parameters like free CO2 and products of phosphate and nitrogen has decreased, but total alkalinity has increased. A noticeable increase has been seen in case of soluble reactive phosphorus and nitrite. Next slide. Now, considering the slide to the extreme left, we have the aerobic mineralization in which is the formula dissolved oxygen concentration by heterotrophic bacterial count. Now, this measured as the aerobic degradation by heterotrophic bacteria and ammonifying bacteria in different ponds of vestibilization pond system employed. Now, coming to the extreme left right graph, we can see that the oxygen demand by denitrifying bacteria measured as an index in different ponds as an inverse function of the swage effluent in maturation ponds. Next slide. So these are the graphs which represents the results with respect to the COD and for both the heterotrophic bacteria and the ammonifying bacteria. Next slide. Now, this is actually after seeing all the results, we can see that the conditions have come to such an optimum level that it has even supported the growth of fish in the maturation ponds. We get a good fish yield, and even it also exhibited reclamation of biological functionality, regulating the diversity and abundance of phytoplankton. Next slide. So here we are concluding. I would like Shomak to please do the conclusion.
Hello, Shomak, are you there?
Shomak, are you there?
Extremely sorry, sir. Was I not audible? I'm so sorry, sir. Yes. So in the conclusion, we've essentially just jotted down the result that we have gotten from the research, that the gradual reduction of nutrient cycling bacterial population resulted in nearly 90% reclamation of sewage. Patterns of changes of oxygen dependent ammonia oxidizing bacteria and cellulose decomposing bacteria was related to the concentrations of dissolved oxygen in the water. Aerobic mineralization index, on the other hand, revealed the pattern of changes in HbAb and the PSB population consistent with ecological resilience of the system as a whole. Facultative pond was the main pond, which shows maximum dynamicity in reclamation of sewage, contributing to around 42 to 67%. Keystone structuring process integrated with engineering resilience, constructed waste stabilization pond, enhanced functional resilience of the system. Effective degradation and mineralization of organic matter was performed by the integral actions of microbial subsystem and oxygenation by the solar energy driven microalgal subsystem. And the stability and harmony of the ecosystem has finally been achieved by the redundancy of different subsystems as well as the feedback mechanism of that system. With that, we would like to thank everyone for giving us this opportunity to present, and our sincerest gratitudes. Thank you.
Thank you, everyone.
Thanks to both of you. Yes, ma'am, you want to ask them something?
No question. Thank you.
Thank you, ma'am.
Both of you, and I think we have come to the end of this session.
So with this, we end the UG presentations. We begin with the PG presentations now. Professor Devjani Dotto and Professor Lupamudra Roy will judge this event. The first presenters are Anshu Shaw and Spandan Vaidya.
Do I start? Yes, you can.
I am there. Lopa, are you there?
Yes, yes.
Okay, okay. Go on. Go on.
Carry on. All the best.
Thank you, ma'am. A very good evening to the respected judges and the audience. Myself, Anshu Shaw, and my co-participant Spandan Vaidya are going to present on HSPC editing, a new strategy for genome editing technology. Genome editing and protein replacement therapy have been quite beneficial in treatment of many life-risking genetic disorders, but however, they exhibit several limitations that lead to treatment failures and limited long-term efficacy. This issue was overcome using a highly transcribed genomic locus like the alpha-globin gene to incorporate and overexpress the missing proteins causing the respective disease. We are all aware of hematopoietic stem cells and their self-renewal property, and owing to this property, they have been used for this technique. The CRISPR-Cas9 system has been used to do the genome editing. Now, moving on to directly the results, 14 guide RNAs, as we can see in the figure, target the non-coding part of alpha-globin locus and has been designed, and the screening has been done in the next experiment. Here in figure B, we can see that it shows the deletion efficiency of 14 different gRNA. The orange and green target the 5' UTR and the blue and purple target the introns. By looking at the maximum indel percentage, the gRNAs were then selected for further experimentation. Okay, so now post the deletion, the HSCs were tested whether they can differentiate into their downstream cells or not. It was well observed that all the downstream cells and markers, be it RBC or platelets or different types of hemoglobins, they all were formed in correct amount. And in the last figure, the alpha to beta globin ratio was seen post deletion. And as we can see here, the ratio was approximately 1 in all the cases, except in knockout KO, where the coding part of alpha globin gene was targeted and deleted. Overall, it shows that both 5' UTR gRNA and IVS2 gRNA could efficiently cut the alpha globin genes without affecting HSPC viability. Yeah, now since we are talking about gRNA and CRISPR-Cas9 technology, we must not forget to mention about the two great scientists, Dr. Emmanuel Charpentier and Dr. Jennifer Doudna, who received the Nobel Prize just 3 days ago for developing the CRISPR-Cas9 tool, which can be used for genome editing on practically all living things. Here we can see the gRNA that is complementary to the target sequence, and the main function of gRNA is to basically guide the Cas9 enzyme to target location for efficient cleavage. Next, the amount of transgene expression was determined using the green fluorescent protein and GFP sorting. As we can see in this figure here, the cassette has ITR, that is inverted terminal repeats, that is needed for packaging in the AAV vector. It has a homology region for homologous recombination into the target and the GFP transgene. As we can see in this figure B here, the 5' UTR gRNA showed higher expression of transgene than the IVS2 gRNA. Hence, 5' UTR gRNA was finally selected. And lastly, in figure C, we can see that the amount of protein expression increased 100 times after stem cell differentiation, thus proving that the alpha globin promoter is a well-chosen locus for transgene integration. Thank you. The next portion will be covered by Spondon.
Thank you, Anshu. And now I'll be talking about the application part of this technology. And we can use this technology in treatment of hemophilia B, which is usually an inherited disorder, but sometimes occur due to spontaneous mutation in the factor IX producing gene present on the X chromosome. So the patient has a defective copy of gene, and we want to insert a normal copy of gene within the patient. But here, we do not want to insert our gene of interest in place of the defective copy of gene. Rather, we want to insert our gene of interest in a particular area within the genome known as 5' UTR portion of the alpha globin gene. But how we will do that? At first, we take the HSPC of the patient, and then we create a cut in the 5' UTR portion of the alpha globin gene using CRISPR-Cas9 technology. And then we transduce these cells with adeno-associated virus vector having this expression cassette. As you can see that in this expression cassette, there is presence of factor IX producing gene, as well as there is a reporter gene. This reporter gene ultimately helps us to select the knock-in cells. And as because this is a hematopoietic stem cell or progenitor cell, it will surely differentiate. And as it differentiates, expression of our transgene will be much more higher. Here the scientists use HUDEP2 as their cell line. And the first figure shows that the amount of F9 mRNA is gradually increasing from the undifferentiated cell to the differentiated cell. This second figure shows the amount of F9 protein present in the medium of the HUDEP2 cell. You can see that most of the integration of our transgene is monoallelic in nature. And the third figure shows why we are using adeno-associated virus as a vector. We are not using lentiviral as a vector. It is because if we use adeno-associated virus, then the amount of F9 protein achieved by this process will be much more higher. So similarly, we can also use this technology in treatment of lysosomal storage disorder also, which is also an inherited disease occurring due to the defect in the gene producing the lysosomal enzymes, so resulting in accumulation of toxic metabolite within the cell. And these are some example of this disease, for example, Ullmann disease, Hurler syndrome, Fabry disease, etc. So similarly, just like the previous case, hemophilia case, here we can also insert our gene of interest in the 5' UTR portion of the alpha globin gene using CRISPR-Cas9 technology and adeno-associated virus as a vector having this expression cassette. You can see in the first figure that the amount of transgene mRNA is gradually increasing from the undifferentiated cell to the differentiated cell. And this figure shows that the amount of cholesterol level in the Ullmann disease patient fibroblast will gradually decrease if we incubate with medium collected from the Lal knock-in erythroblast. You can see that in case of the untreated case, the cholesterol level is quite higher. But in case of the Lal knock-in case, cholesterol level is gradually decreasing. So till now, I have talked about the ex vivo part. Now I will talk about the in vivo analysis. Here we transplant the NSG mice with our edited HSPC having our gene of interest because we want to know whether our edited cell retains its homing, engraftment or multi-lineage potential or not. So this is a figure that shows the amount of GFP positive cell present in the NSG mice. You can see that NSG mice transplanted with AAV and RNP treated HSPC will show maximum amount of GFP positive cell. But in case of the untreated and only AAV treated part, there is no GFP positive cell. It means our cells retains its multi-lineage potential. And this is a figure of Western blot analysis. This figure explains that the NSG mice transplanted with AAV and RNP will produce the LAL enzyme, but in case of the untreated and AAV treated part, there is no LAL enzyme production. It means our LAL enzyme is still producing in vivo also. So coming to the discussion and the conclusion part, we can say that though this technique has a lot of advantage, still we need to explore some alternative DNA delivery system, for example, IDLV and non-viral vector. So we can conclude that 5' UTR portion of the alpha globin gene is an excellent safe genomic locus for the integration of our transgene. And as because this place is under the control of a strong endogenous promoter, expression of our transgene will be much more higher. And obviously, future in vivo tests will surely elucidate the therapeutic potential of this CRISPR-Cas9 based genome editing technology, and it can surely be alternative for protein replacement therapy. And these are some references from which collect our data. This is the mother paper published on the Nature on 29 July 2020. And from this article, we gather information about the CRISPR-Cas9. Thank you all.
I have a question.
Yes, ma'am.
Can you hear me?
Yes, ma'am. Yes. I can hear you.
Okay. So you spoke about HUDEP2 cell lines.
Yes, ma'am.
Has been used for your work over here.
Yes, ma'am.
What is it basically? And
ma'am, the full form of HUDEP is a human umbilical cord derived erythroid progenitor cell. Here we are saying that we are editing the HSPC. The full form of HSPC is hematopoietic stem cell and progenitor cell. And HUDEP2 cell is a progenitor cell. It will produce the further erythroid lineage. That's why we are using HUDEP2 cell.
Okay. Okay. Thank you. Lopa,
okay.
you have.
Yes. Okay, I have a question.
Yes, ma'am.
Any one of you can answer that. Is there any comparative data of what happens when this expression cassette is introduced to any other site apart from 5' UTR?
Yes, ma'am. There is a in our genome there are three safe sites where you can insert our gene of interest. It is a safe site. It will not create any insertional mutagenesis. One is 5' UTR portion of the alpha globin gene. Another is AAVS1, adeno-associated virus site 1. The another part is the CCR5 receptor. This CCR5 receptor coding gene is a receptor for the HIV virus. So if you can delete this gene, then obviously the patient or the person will be HIV resistant. So there are obviously some data where we can insert our gene of interest other than the 5' mutant portion of the alpha globin gene.
Also, ma'am,
Okay.
here the alpha globin genes are mainly focused because the alpha globin gene has 4 allele, and even if there is a mistake in the deletion, then even if there are 3 genes deleted, then also there will be no such symptom. Only after all the 4 alleles are deleted, then the patient will be thalassemic. Otherwise, it is a safe locus. That is why this is used.
Okay, thank you. Thank you, both of you. Very nice presentation.
Yes,
Thank you,
good
ma'am.
presentation, well explained.
Yes,
Thank you,
yes.
ma'am.
Can we stop the share?
Yes.
Yes, of course.
Thank you, Anshu Shaw and Spandan Vaidya. The next presenters are Devdatta Das and Shubhajit Chakraborty.
Can we start?
Yes, go ahead, go ahead.
Yes, go ahead.
Devdatta, please share the screen.
Yes. Just a moment. Is it visible?
Yes, it is visible. So I'm starting. Good evening, everyone. I am Shubhajit, and today myself and Devdatta will be presenting on the topic removal of manganese and other heavy metals from contaminated groundwater using a novel bacterial isolate, a study built on synchrotron-based techniques. So as our paper is based on groundwater, so first of all, we must know the importance of groundwater to humans. Now 70% of Earth's surface, as we know, is covered with water. But as the poet has said, water, water everywhere, nor any drop to drink. Only 2% is fresh water. And out of the 2%, majority is in the poles. Only 13% is fit for consumption. And even out of that 13%, groundwater constitutes the majority of it. And so it is an important source of drinking water to mankind. Now the surface water does not generally contain large amounts of manganese, but in groundwater systems, manganese is often found frequently. So everyone might be wondering why manganese out of all these metals. This is because high concentration of manganese in groundwater is a serious worldwide problem. WHO has given the permissible limit of manganese in groundwater as 0.1 mg per liter. But at concentrations greater than this, there may be plumbing problems. For example, clogging of water pipes, colored water, which is actually looks very nasty, as you can see, pipe rusting, etc. Now, if the concentration is greater than 0.2 mg per liter, then it may cause serious health problems. For example, neurotoxicity in humans and animals, Parkinson's symptoms, emotional instability, toxicity to cellular metabolism, etc. So there must be some processes to remove the manganese from groundwater. The traditional method includes the conversion of soluble manganese to insoluble manganese through oxidation by chemicals like free chlorine and permanganate, and then they are separated out by sedimentation or filtration. Now, an even better method has been used, which is the alternative method, that is biological oxidation by manganese removing microorganisms. And the advantages of this method are easy installation into the treatment system, the cost is low, and it is also eco-friendly as the chemicals are not used. So the bacteria which were previously used in this job, such as Acinetobacter, Leptothrix, etc., they were usually isolated from regions where the manganese concentration was normal. But these bacteria may not perform well, may not even survive in places having greater manganese concentration. So it would be much better if we use indigenous cultures, that is isolated from contaminated sites themselves. So in the study we are focusing on, 21 bacterial colonies were enriched from soil and groundwater filter medium from 2 districts of Thailand. Now as you can see, there were 3 sources from which the colonies were extracted, and they were given 3 different strain names. Now these colonies were tested for manganese oxidation potential by LBB spot method. Now this method shows up the result that manganese oxidation potential was positive for 6 out of the 21 replicates, and these 6 were further tested for manganese removal efficiency for 7 days at an initial manganese concentration of 5 mg per liter, and 3 out of these 6 isolates showed highest manganese removal efficiency, SBP1, SBP3 and SBP7. Now these strains should be identified. So they have what was done, 16S RNA gene sequencing was done, and SBP1 showed similarity to Streptomyces violaris, SBP3 also Streptomyces violaris, and SBP7 to Chrysobacterium cucumeris. And this is the first report of manganese removal by these kind of bacteria. These three strains were further investigated for manganese removal efficiency and for their bacterial growth as MLSs in synthetic groundwater. The time of experiment was 36 hours. Initial manganese concentration was 5 mg per liter. And the results, as you can clearly see, SDP1 excelled at 47% manganese removal efficiency and bacterial growth highest at 69 milligram per liter. Streptomyces violaris SBP3 fared a little less at 42% and Chrysobacterium cucumeris was unfortunately last at 9%. So from now, Devdatta will be taking over.
Thank you, Shubhajit. The bacterial growth kinetics of SBP1 were estimated using the monod model, taking specific growth rate mu against an increasing manganese concentration. Two different bacterial consortia from biofilters were taken as control, and as seen in this table, the new max for SBP1 at 1 milligram per liter manganese concentration is considerably high. This indicates that this bacteria grows pretty well in the contaminated environment. The mu for SBP1 increases up to 1 milligram per liter manganese concentration and thereafter remains constant till a high manganese concentration of 30 milligram per liter, where cell substrate inhibition takes place based affected by the IBA model. Now, SBP1 was able to remove manganese from both synthetic and natural groundwater. It removed manganese with the high efficiency of 46%, as well as other harmful contaminants like iron and arsenic, with efficiencies as high as 81 and 38% respectively. Two different natural groundwater sources containing high amount of metal ions and anions that affected the bacteria's growth and oxidizing activity, and also which was low in nutrient availability. SBP1 still showed a manganese removal efficiency of 23% in such water samples. Now, synchrotron-based techniques were used to understand the manganese removal mechanism by SBP1. First, sem-EDS analysis was done to understand the bacteria's morphology, and it was found that the bacteria was rod-shaped. Through this, it was also found that after a 2-day manganese removal experiment, where the bacteria was constantly exposed to varying concentrations of manganese, there was no change in the morphology of the cell. This proved that high manganese concentration could do nothing to harm the cell's surface and, in extension, the cell's survival. This picture, obtained through sem-EDS analysis, the rod shape of the bacteria, undistorted, is quite evident. However, sem-EDS did not find any trace of manganese on the cell's surface. Hence, further synchrotron-based techniques, namely XPS and XANES, were performed using the X-ray diffraction beamline. XPS found a number of elements on the cell surface, and this time including manganese. The characteristic peaks in the magnified absorption spectrum of manganese corresponding to various oxidation states of manganese is quite evident. XANES was conducted to confirm the oxidation state of manganese which was found on the cell's surface. First, the manganese K edge of the cell was plotted against the different oxidation states of manganese that were taken as standards. Then, a derivative graph was prepared to calculate the oxidation absorption energy of manganese. It was found that the oxidation states of manganese were Mn2 plus and 3 plus on the cell's surface. These techniques confirmed that manganese was removed from the water by the cell with a combination of oxidation and adsorption. Using cells in combination with biocars has an even increased efficiency for manganese removal. Biocars are wood waste obtained from the wood vinegar industry, and when modified with hydrogen peroxide has an increase in the oxidizing groups present on it. The cells, when used as an immobilized biofilm in association with biocar, is called cell immobilized biocar, and it has a manganese removal efficiency as high as 78%. This picture diagrammatically represents the association between cell and the biocar. Now, as previously discussed, the biological method of oxidation in treatment plants is better than the chemical method. However, using SBP1 is an even better option because SBP1 normally grows in the contaminated environment. Hence, it naturally has a high tolerance against varying concentration of manganese. In biological method, only oxidation is used. SBP1 combines adsorption with it. And the enzymes involved in the oxidation process is multicopper oxidases and peroxygen cyclooxygenases. Now, to summarize our presentation, SBP1 was selected among 21 different isolates because it showed the highest manganese removal efficiency and also removed iron and arsenic. The monod model depicted the bacteria's growth kinetics. Cell substrate inhibition beyond 30 milligram per liter manganese concentration was depicted by the IBA model. sem-EDS was used to understand the bacteria's growth kinetics. XPS and XANES proved that manganese was removed by the bacteria with a combination of adsorption and biooxidation. Cell immobilized biochar has a high manganese removal efficiency of 78%. Finally, using SBP1 in water treatment plants has huge future prospects since this provides a highly efficient, economical, and environmental friendly method of removing not just manganese but also other harmful contaminants like iron and arsenic from water. Now, these were the references that were used for this presentation. Finally, thank you, respected judges and my dear friends, for your kind hearing.
Okay, Devdatta, may both of you, any one of you can answer actually. See, you spoke of this typical streptomyces species, which had been derived from the sample that has been taken from Thailand, if I'm not wrong. Thailand was the place, right?
Yes, ma'am.
Yes. So is there any chance, I mean, have you looked into literature and seen if this organism is available on Indian climate or can grow and sustain an Indian climate? So that we can also be using it here, or it's a very regional kind of a study and effective only in a regional manner?
Ma'am, actually, this study is quite recent. It was published in August, this August actually. So, for this particular type of strain, means this particular type of genus, no study has been yet, as of yet, done in India.
But, ma'am, since manganese contamination is a worldwide problem, and it is quite evident from this study that this bacteria grows pretty well in any sort of manganese contamination, be it in India or in Thailand. So, it can be concluded that this bacteria is available in any sort of manganese contaminated water. And particularly in West Bengal as well, the manganese contamination in groundwater is a pretty big problem. So we can easily find this bacteria in the contaminated water. However, studies regarding this has yet not been done, because as Shubhajit said, this is quite a very recent study. So as of now, the bacteria has only been isolated from Thailand.
Yeah,
This
that is what
particular strain.
that is why I wanted to ask you, because it's a major problem in West Bengal as well. So if conditions for
Yes, ma'am, but this bacteria can be very well inoculated in any sort of water plant in West Bengal as well, because they grow at high manganese concentration. As I explained, that 30 milligram of manganese concentration, the bacteria is still growing. So it can be inoculated in water treatment plants even if it is in West Bengal.
no, I wanted you to look into certain other parameters about the growth conditions of this organism. Okay, just maybe you can look over not only the manganese tolerant, there may be there are definitely other conditions which are also allowing the growth of the organism in some particular region. So those conditions. Okay. Anyway, thank you for your answer. Over to Lopa.
Yes, a very nice presentation. Actually, that was my question also, whether this organism is can be grown here also in Indian perspective, whether it is applicable or not.
Yes, ma'am.
Okay. And
It can grow in any manganese contaminated region actually. Studies have not yet been done in India particularly, but it can grow in manganese contaminated regions. So if further studies are done, then it may be possible that it can be used here also.
And this bacteria has the future prospect of being used in the treatment plant. So it should be done. The studies, further study should be done.
Exactly.
Okay. Thank you.
Thank you, ma'am. Ma'am, should I stop the sharing now?
Yes, go ahead. We want the next presentation. Thank you, both of you, Devdatta and Shubhadeep.
Yes, ma'am.
Thank you, Devdatta Dash and Shubhaji Chakraborty. The next presenters are Shayantan Josh and Shayantan Shaha.
Is the audio audible?
Yes, you are audible.
Okay, thank you, ma'am. So today, myself, Shantan Shah, and my friend Shantan Josh will be taking you through a technology which is recent and has made a tremendous name for itself in the past 2 days. As you have guessed, it's CRISPR-Cas9. So what is genome engineering? It is the ability to remove or add particular nucleotide sequences in the genome. One might ask, what's the deed? So the needs are dependent on the range of application, which can range from prevention and treatment of human diseases to genetically modifying crops for better yield, and then production of personalized medicines, production of transgenic vectors. And then you can ask that how it is achieved. Well, the path was laid in 1969 by this person, Hamilton O. Smith, who discovered the type 2 restriction enzyme from Haemophilus influenzae. Then the modification of the nucleases took a huge role in the editing of the genomes, and ZFN and talents were the most pretty widely used nucleases. In case of ZFN, the zinc finger domain consists of a 2-cysteine 2-histidine residue bound to the zinc atoms, and they recognize 3 nucleotide triplets. In case of talons, the DNA binding domain is more specific because they recognize only a single nucleotide. And in both the cases, the FOC1 endonuclease is used, which is derived from the Flavobacterium species. Both the techniques have some drawbacks. That is, they are not easy to manufacture, they have high economic cost, and the design of the target region is very tedious. Then comes the discovery of the CRISPR in the 1987, when the first report was published by the scientists of Osaka University, who showed that while cloning the gene for the alkaline phosphatase, they discovered the CRISPR sequences. Then, in 20 years later, Radolf Baranju in the food industry Danish scope had showed that the systems are used by bacteria as a source of adaptive immune system. Then in 2012, the program-specific target location was used, and then in 2015, the cancer cells were reversed to normal cells. So why is CRISPR so important? CRISPR stands for clustered, regularly interspaced, short palindromic repeats, and are the RNA-based bacterial defense adaptive mechanisms, and are present only in archaeas and bacteria. The Cas9 is the associated endonuclease. So some of the advantages that CRISPR offers, and pretty much why it is widely used nowadays over Zerifin and talents, are the target design simplicity, efficiency, and accuracy, and the multiple mutations that you can alter the genome with. As much as 5 mutations can be done in single attempt. The elements of CRISPR are spacer DNA, CRISPR repeat RNA, the tracer RNA, the guide RNA, the Cas9 nuclease, and the PAMs. Here we can see the CRISPR at work. This is the host bacterial cell in which the foreign DNA has invaded. The foreign DNA contains the target and the PAMs. The bacterial genome has a CRISPR loci in which the CRISPR RNA is transcribed. The bacterial RNA polymerase also transcribes tracer RNA, which combines with the CRISPR RNA to form a scaffold to which the Cas9 binds. The Cas9 then cleaves the dsDNA or the invading DNA and making a double-stranded break in the genome of the invading pathogen. When the CRISPR-Cas9 nuclease is added with the activator, it is called as CRISPR-A technique or the activation technique, and if with inhibitor, it's called inhibitory technique. This is Jennifer Doudna holding the 3D model of the CRISPR-Cas9, in which the Cas9 is the white domain, the orange domain is the guide RNA, and the blue domain, the blue thing is the DNA target DNA. What Jennifer Doudna and Emmanuel Charpentier did was to fuse the tracer RNA and the CRISPR RNA into one, forming the guide RNA. Next part of the presentation and the application will be carried on by Stanton Josh.
Sorry. Good evening, everyone. I'm Shantan Josh. I will be talking about the applications of CRISPR. So CRISPR can be used to treat monogenic disorders, that is, they have mutation in a single gene, or it can be used to manipulate virus receptors. It can be used to create genetically engineered T cells for specific cancer cell binding for drug discovery, and to create the entire genome map of disease models, and to visualize the gene translocation between two chromosomes. It can be used to produce genetically modified crops and to treat various diseases. Next. CRISPR-Cas9 is used widely in hematological disorders such as thalassemia and sickle cell anemia. Both have mutation in the beta globin gene of the hemoglobin molecule, as a result of which the hemoglobin agglutinates and there is scarcity of oxygen in the tissues. So how can it be fixed? We can either knock out the entire mutated beta gene from the total hemoglobin molecule, or we can swap from beta mutated beta gene to gamma gene. The gamma gene is present in fetal hemoglobin. That is, it is present in fetus. So what happens here? During the stage of maturation, the gamma gene is converted to beta gene by the activity of BCL11A gene product. So if we cleave this gene or its enhancer, the gamma gene stays as alpha 2 gamma 2 tetramer in the form of human fetal hemoglobin. And as a result of which, the mutated phenotype can be suppressed significantly. Next. So when we entirely knock out the BCL11A gene, we find there is a drastic increase in the gamma gene, as well as there is an increase in the fetal hemoglobin molecule in the blood. So what happens in the machinery? Let's go to the machinery. The guide RNA, the spacer sequences, the enhancer molecules, the entire machinery is cloned into lentiviruses and then transduced into cells and then sorted out or screened based on their HbF levels. Now we can also find the gap between the two cleavage points using this technology. So in the picture in the right, we can see that this is just the summary. We can see that the BCL11A gene is knocked out by the CRISPR technology, as a result of which there is HbF activation and suppression of the mutated phenotype. Next. CRISPR in cancer is generally used in immunotherapy and to treat refractory cancer. That means the cancer which has become drug resistant before or after treatment. So we take normal T cell from the patient, run it through Cas9 technology and knock out certain genes, the TRAC gene, the TRBC gene, and the PDCD1 gene. The PDCD1 gene is the programmatic cell death protein gene that if we knock out this gene, it reduces the chance of autoimmune toxicity. So we can also integrate NY-ESO gene in this T cell. NY-ESO gene functions, the T cell receptor functions to properly bind, specifically bind cancer cells. And this procedure is done with the help of lentiviral vectors and injected back into the patient. In the right-hand picture, we can see that fluorescence probing has been used to measure the NY-ESO levels in different patient samples. And the disruption, the percentage disruption of genes in different patient samples is also done by fluorescent probing, as shown in the graph. Next. CRISPR versus COVID. We know COVID is now a very big emerging problem of the society. So coronavirus has two major gene parts, the E gene region and the N gene region. E stands for envelope gene and N stands for nucleoprotein gene. So we can use fluorescent probes that can characterize or categorize the type or strain of the coronavirus. If the N gene is expressed more in the fluorescent probe, then it can be said that it is either SARS-CoV-2 or bat coronavirus. But if the E gene is expressed more, it can be said that it is coronavirus related or associated strains. This is the picture of a small kit of the CRISPR technology used in coronavirus testing. So how it is done? We first take the nasopharyngeal swab from the patient, extract the viral DNA from it, run it through reverse transcriptase PCR so that we can get the DNA sample. We complex it with Cas12. Cas12 is a more precise nuclease than Cas9. It can cleave the gene, the viral gene from the DNA, the N gene and the E gene part, and through lateral strip analysis, we can now test whether the patient is positive or negative. When both the genes are present, it is said that the patient is SARS-CoV positive. If either of it is present or absent, if N is present, E is absent, then it is preferred to say that maybe the gene, the virus strain is present or may not be present. This is not a surer test. If both is present, then that becomes a more surer test. But if everything is absent, including the RNSP from the human, if that is also absent, then the test may have failed. So we have to start from the beginning. Next. CRISPR can also tell us about live cell dynamics. We can see live cell dynamics using this process. So here we use fluorescent proteins like YFP. We separate the proteins into two parts, the YF part and the protein and the FP part, and we introduce a spacer sequence and a target sequence in between them, which can be chewed off later by the Cas9 protein. If these are chewed off, these sequences are chewed off, then what happens? The YF and the FP part comes close enough to form the entire YFP molecule, and as a result of which the yellow fluorescence emits. So in the first panel, we can see that there is no action of Cas9 protein. It is just the 35S YFP. And 35S is, by the way, is the promoter. As it is written above, 2x35S is the promoter sequence found in Lotus japonica. This experiment is done in Lotus japonica. So this may be said as the positive control, with chlorophyll being showing autofluorescence. Now we come to the next middle panel. We can see that here the Cas9 activity is not shown, is not active. So what happens? The YF and the FP part are far enough and they cannot emit that much amount of intense yellow light. So the light, the shade of the YFP molecule is a little dim or blurred. Now we get on to the next and the bottom panel. We can see that the Cas9 protein is now active. It chews off the entire spacer sequence and the target sequence, and then it merges the two YF and FP part to maintain a complete YFP molecule and thereby showing yellow fluorescence. Next part will be continued by Shantan Shah. Thank you.
Okay, so as we know, every technology comes with its positives and negatives. So does CRISPR. In the case of CRISPR, the germline editing is considered as a negative, or a something which is not with the nature, with the flow of nature, and is against the nature. So scientists have called for a moratorium or a pause on the germline editing processes until more seriously it is understood and the guidelines are developed. Next, we can see them. They are pretty known now. Jennifer Doudna and Manuel Charpentier, who developed the process, and this is a paper they wrote in 2012 for which they got the Nobel Prize 2 days back. Our choice of the topic was purely coincidental because it happened before the declaration of the Nobel Prizes. And these are some of our references. And if you're still thinking about designing of super babies or superhumans by genetic modification or editing, that might come costly. Thank you.
Okay, I quite like the presentation. And basically, I don't have any questions to ask you, whatever you have presented. I have no questions.
Okay.
Lopa, she might be
Thank
asking.
you, thank you. And wanted to just you to explain once more how CRISPR-Cas9 is being used in cancer research. Just explain it once more.
Yes, ma'am. Ma'am, actually, it is specially used in
And
refractory.
which types of cancer? That I also wanted to know. Which
Excuse me,
types
sorry,
of
ma'am?
cancer? Which types of cancer it is?
Ma'am, it is actually used in refractory cancers. That is, the cancers which have become drug resistant, fourth stage cancers that have become drug resistant. They are not activating, or they are not showing any changes in chemotherapy. So then we use CRISPR-Cas9 system.
Okay. Okay, thank you.
Thank you, ma'am.
Okay. I'm stopping the presentation, ma'am.
Yes.
Thank you.
Thank you, Shantan Josh and Shantan Shaha. The next presenters are Gaurav Dipto Banerjee and Koel Biswas.
audible?
Your voice is cracking.
Okay. Is it okay now?
No, and your video is also not visible.
My video is not visible. Wait a minute.
Okay, yes, it is now. Okay,
Okay, maybe now I'm visible. Please confirm if I am visible.
it's not. Could you try once more, please?
Yeah, sure. Am I visible now?
Yes, you are visible.
You
You can
are.
continue. Yes.
Okay. So, good evening, everyone. I'm Gaurav Banerjee, and my friend Koel Bishash will be talking on the topic silvainositol, a potential therapeutic agent for Alzheimer's disease produced by bacteria cell factory. Next slide. What is Alzheimer's disease? Alzheimer's disease is one of the most common and problematic forms of dementia in adults, which recently reached a worldwide prevalence of about 50 million people. Alzheimer's affected brains are mainly characterized by the formation of two pathological hallmarks like neurofibrillary tangles and amyloid beta plaques. So, Alzheimer's disease can be regarded as a degenerative brain disorder. Next slide. This picture clearly shows the basic difference between a normal healthy brain and an Alzheimer's affected one. In the latter case, it can be seen that the brain volume decreased considerably due to neuronal damage. The accumulation of beta amyloid initiates a series of events, including activation of cell death program, oxidation of lipids, cell membrane disruption, and many others. All these correlate to neuron loss and ultimately lead to apoptosis.
Gaurav, are you there?
Yes, ma'am. Yes, ma'am, I'm here. Actually, having some problem with my connection. I can see the slides here. No.
What connectivity you are using? Gaurav? You can,
Yes,
you
ma'am.
can take the help of your mobile connectivity.
Yes, sir. I'm using Vodafone connection.
Then why it is happening so?
No, it was all right. I can see the slides. That's why. Can I join once again, if possible? I'm leaving the meeting and joining once again.
Why don't coil present? Vital time is getting lost.
Sir, I am here. Sir, I am here.
Okay, please
Sir,
continue.
yes, sir, I'm here. Yeah, I have joined once more. Okay. So, to curb Alzheimer's, it is necessary to block the formation of amyloid beta plaques, which mainly consists of the peptide A beta 42 having around 36 to 43 amino acids. A rare stereoisomer of inositol called siloinositol has been reported to stabilize a conformer of A beta 42 in vitro. It also helps in neutralizing cell-derived AB trimers, thus promoting low molecular weight AB species in vivo. All these interactions lead to reduction in neuronal toxicity as well as increased long-term potentiation, and consequently it helps in removal of cognitive deficits in various mouse models. Next slide, please. Okay. So here the graph showed the therapeutic administration of siloinositol in a TG rat model reduced the amyloid beta load. In the A diagram, we can see that after siloinositol administration, the amyloid beta plaques decreased in the hippocampal region, which is responsible for retaining long-term memory. The same thing, what I explained in picture A is explained graphically in the B picture. That is, the percentage of hippocampal area covered by amyloid beta plaques is significantly reduced. In graph C, we can see that plaques of all sizes are observed to be reduced. And the graph D shows us that the clearance pathway, which is the neural clearance pathway, did not remove the siloinositol so that it can be effective against Alzheimer's disease. Next. So the next part will be taken over by Joel.
As Gaurav explained, it is clearly obvious from clinical investigation that siloinositol has been showing greater therapeutic potential towards treating Alzheimer's. But such clinical phase trials and possible developmental treatments require a large scale of siloinositol, which is non-economical. So what is done here? To combat this problem, a unique Bacillus subtilis cell factory is formed where it is genetically modified for converting myoinositol to other inositol stereoisomers. Why Bacillus subtilis cell factory is chosen? Because it is one of the best studied gram-positive bacteria and it has the IOL operon, which transcribe enzymes that are responsible for metabolizing inositol. Now, the key enzyme for myoinositol biosynthesis, that is myoinositol 1-phosphate synthase, MI1PS, is not inherently present in Bacillus subtilis genome. Okay. So how this Bacillus subtilis is genetically modified? Mycobacterium tuberculosis, another gram-positive bacteria like Bacillus, has INO1 gene encoding MI1PS. And the modified INO1 gene is cloned into the MUI locus of the chromosome of the Bacillus subtilis parental strain 168, so that the enzyme can be synthesized constitutively under the RPSO promoter. Now, the mechanism of cloning, what I described just now, is depicted in this picture. In Bacillus subtilis, the siloinositol is produced by interconnecting to conversion process. First, glucose is converted to glucose 6-phosphate, which is a substrate for the key enzyme myoinositol 1-phosphate synthase, and it is converted to myoinositol 1-phosphate, and then it is dephosphorylated to myoinositol by inositol monophosphatase. Then after myoinositol is produced, it is again oxidized to siloinosose by the enzyme IOLG. It is an inositol dehydrogenase, and siloinosose is further reduced to siloinositol by another inositol dehydrogenase IOLW. Okay. Bacillus subtilis has PBV gene which encodes purine efflux pump. When the intracellular concentration of purine base increases inside the cell, the gene got induced and it drains out excess purine outside of the cells to maintain homeostasis. Now, it is seen that under normal condition in Bacillus, the level of NAD plus NADH remains very low to make the enzyme MI1PS to stabilize. But again, MI1PS needs essential cofactors like NAD plus NADH to retain its functionality. So what is done here? And now the essential cofactors has to be properly located in the Roseman fold domain of the enzyme during the translation of the enzyme. Okay, so now what is done here? The PBV gene is inactivated so that the purine accumulates inside the cell, and which might help to resynthesis of the essential cofactors used by the enzyme MI1PS. Now, in the right hand side, the graph is shown where column 1 represents Bacillus subtilis parental strain 168 and the column 2 represent Bacillus subtilis YDHLD. The parental strain where the BPV gene is not inactivated, but the column 2 that where the gene is inactivated and it gives rise to higher NAD plus NADH concentration. Okay. For more silane production, the three strategies have been acquired. First, an artificial pathway is introduced where involving two inositol dehydrogenases, namely IOLG and IOLW. And it is observed that IOLW plays an active role during the conversion of silanosis to siloinositol. And to favor this process, the medium is enriched with 2% bactosoitone. Now, glucose is uptaken into the cell via phosphophenol pyruvate dependent phosphotransferase system. Now, an additional mechanism is introduced where the two glucose transporters that are GLCP and GLCK are overexpressed so that more glucose 6-phosphate to minoxidil conversion is possible, followed by increasing concentration of silanoxidil. Okay. So the glycolysis and PPP are the major pathways for glucose metabolism. It consumes a huge amount of glucose 6-phosphate and leaving behind a limited amount of it for converting into myoinositol. In order to direct more silanoxidil production, the two key enzymes that play a vital role in these pathways could have been planned to be manipulated in near future. The enzymes are glucose 6-phosphate isomerase and glucose 6-phosphate dehydrogenase. Now the diagram will be explained by Gaurav again.
So this diagram schematically shows the process and the strategies what Koel explained just now. Just to add here, we can see that it can be seen that Mi1PS, which is denoted in magenta color, has been heterogeneously introduced, and all other transporters and factors which are blue in color are overexpressed. Next one. Okay. We can conclude here that siloinositol is a significant therapeutic agent which helps us to challenge the growing problems of Alzheimer's disease. The bacterial cell factory will ensure an inexpensive way, which is almost 3 times cheaper than the previously established methods to produce this rare compound siloinositol from glucose. Next one. Now we have some future prospect. We know that although siloinositol showed promising benefits on treatment of mild to moderate Alzheimer's disease, however, there are some limitations on dosage regimen because high dose of siloinositol may cause renal dysfunction and hyperuricemia. So a new strategy may be acquired where a guanidine-appended siloinositol derivative known as AAD66 having excellent blood-brain barrier permeability resulted in more effective reduction of amyloid beta plaque deposits, gliosis, and behavioral memory deficits. Therefore, AAD66 can be used as a better substitute for siloinositol for efficacy with minimum adverse side effects in near future. So this is the reference paper that we are presenting, as you can see. Thank you.
Thank you, Gaurav and Koel.
Thank you.
I have a simple question.
Yes.
Yeah. Can you tell me where this xyloinositol is? I mean, the source in nature. Can you tell me the source of this compound in nature? Where will you find it from?
Ma'am, it is derived from phytic acid, and it's seen that in the parts leaves.
Leaves.
Ma'am. Yeah.
Leaves of what?
Ma'am, as we know that some plants like coconut have like plant tissues. As I've read somewhere that some plant tissues may contain siloinositol in small amount.
Okay.
In first leaf it is found.
Yes, like as you can see, like coconut or something. Yes, in some plant tissues of coconut, siloinositol is found.
and it's derived from phytic acid.
And here we are like glucose, we are converting it from siloanisole. Here we are getting from glucose actually. Our mechanism says that how can we derive siloanisole from glucose via myoanisole pathway. Yes.
Okay, thank you.
Thank you.
Okay. Uh, Gaurav and Koel, nice presentation. And I wanted to ask you that the novel derivative that you told in your last slide, AAD66.
Yes, ma'am.
Can you
AD66.
highlight?
Yes.
Can you highlight what is its mode of action? How does it work?
Yes, ma'am. Basically, it's still under research. It's not. It's under clinical trial. Basically, due to because cycloanisole had some adverse effects, some side effects, which are related to kidney, like renal failure, hyperuricemia, that is the uric acid deposition. So, scientists are working so that some new compound can be derived from cycloanisole, which has the same function of cycloanisole, but barring the main like the limitations can be eliminated, so that so AAD66, it's a guanidine derivative. 6 guanidine is added to the siloinositol, and the main advantage is guanidine has very good blood-brain barrier permeability. So it can spread, it can enter and spread within the brain more swiftly than siloinositol.
Okay, okay.
Also there the side effects, here the side effects are getting eliminated, so that's a added advantage in this case. That's good.
Thank you, thank you.
Thank you, ma'am.
Okay, ma'am, stop sharing.
Yes, yes.
Thank you, Koel and Gaurav. The next presenters are Moitri Sharkar and Tanisha Biswas.
Is my screen visible?
Yes, yes, it's visible.
Okay, thank you, ma'am. So good
Carry on.
evening, everyone. Our topic for today is nanobionics, a world within the world where technology dares. So what is nanobionics? Nanobionics, uh, nanobionics is a field where biological systems are modified and they're modified to provide solutions to our modern day problems. Me, Moitri Sarkar, and my dear friend Tanisha Biswas will be talking about applications of nanobionic, one in the plant world and two in the animal world. So I'll begin with the plant world. So light emitting plants. Why are we talking about light emitting plants? Because energy crisis is a very real thing right now, and to find non-electrical sources of light emission is of utmost importance. And why are we discussing plants? Well, because plants are known to have a huge storage of unused energy which can be tapped into for making for useful making of useful engineering applications. In this respect, a common question is why not genetically modified plants? Well, they have been worked upon before, and the limitations are there's a very narrow range of plants that can be worked upon. And since the most common method of production of light in plants is the firefly luciferin luciferase pathway, luciferin is shown to have a higher level of toxicity in the plant, which is why we find nanobionics to be a very probable solution to the problem. So how is this working out? What happens is the needed enzymes and the needed particles, like in this case luciferin luciferase as well as coenzyme A, are associated with nanoparticles that are made up with silica and in some cases polylacticoglycolic acids and chitosans, and they are inserted inside the plants in a noble method known as pressurized bath infusion of nanoparticles. Upon insertion inside the leaves, these particles spread and redistribute as far as their size as well as charges, and exploiting the innate ATP, magnesium ions as well as the oxygen ions of the plant itself, light is emitted. And we'll see in this reaction how luciferin is being oxidized by luciferase to produce light of around 560 nanometer, which, by the way, is a good amount of light to be produced. And in the picture in the right, we see how these particles are getting distributed in the mesophyll of the leaf, and the larger particles remain in the mesophyll layer, whereas the smaller ones enter the cytosol, which has a higher, much higher concentration of ATP than the extracellular level does. So what are the factors that affect light emission, and as in factors affecting light emission in terms of duration as well as intensity? Well, why are we adding silica and PLGAs? These are shown to extend the duration of light emission. For example, and also point number 2 would be when these particles are being inserted inside the plant, the pressure is of critical importance, nothing more than 0.04 bar per seconds, nothing less than 0.02 bar per seconds. Concentration plays an important role as well. We might think more the merrier, but so is not the case. The enzyme concentration has to be optimized. Incubation time plays another important role. However, the catch in this slide is the on and off switch, which is why these plants are favored over genetically modified plants. That is because in the previous reaction, we saw a byproduct of dehydroluciferyl adenylate, which is a strong inhibitor of the reaction and can turn off the lights. And it can be turned back on by the addition of coenzyme A, and that's a brilliant point. And moving on to the final slide, watercress plants were worked upon, and these plants had shown to emit light of which is 50% of 1 mu watt of commercial LED lights of today's world. And other than that, before this, there has been only one another plant, Nicotiana tabacca, which has been genetically modified. However, nanobionics approached plants show 100,000 times brighter light and also 10 times longer duration of light production. And as this picture shows, it's in the lab where a famous book, Paradise Lost, is being lit by these plants for continuously 7 hours. So with the hope that in some near future, we'll be seeing our streets lit by plants and we'll walk towards a more sustainable life, I'll now request my partner Tanishta Biswas to talk about nanobionic applications in the animal world. Tanishta, on to you.
I'll be taking over now, and I'll be now talking about the impact of nanobionics in the animal world by introducing sperm micromotors or sperm bots. So when we're talking about micromotors, the question arises is that why not use artificial micromotors? Since they have been in the market for the past few years, they have been talked about. Principally because we are talking about introducing micromotors in the complex human blood. So blood, as we know, is a complex circulatory fluid because of its pH, as well as the presence of several other cells in the blood provide principal resistance to the micromotors. Moreover, the innate immune response also does not allow the micromotors to work properly. Then the question arises is why not normal sperms? How about normal sperms delivering the cargo to the target sites? Well, normal sperms, when introduced in blood, they tend to follow circular trajectories after a certain point of time, and they're unable to escape from there. Hence, the solution for us is sperm bots. So what are sperm bots? Next slide, please. So why sperm bots? The reasons. Moitri, next slide. Thank you. So sperm-based micromotors are sperm bots. What are the reasons why I'm talking about sperm bots? Are number one, sperm's ability of powerful propulsion because of the presence of its flagella. Secondly, it's rheotaxis, that is swimming against the flow of blood, and thigmotaxis, that is swimming along the boundaries, very close to the boundaries where the blood velocity is very less because of stress. Third is the membrane composition of the sperms are similar to the membrane composition of the cells of our body. Moreover, we are talking about a sperm bot, that is, there's a presence of an additional cap, that is a streamlined horned cap, which provides a magnetic guidance to the sperm bots for delivery to the target sites. Moreover, the sperm bots do not secrete any harmful factors and can also suppress local immune responses because of the presence of certain cluster of differentiations and factors on its surface. Now I'm talking about cargo delivery by sperm bots. What cargo? In this case, it's heparin in an in vitro setup which mimics the human artery. As we can see from the picture, that there is a magnetic guidance, an external magnetic guidance that is provided. The blood is inserted inside the in vitro apparatus, and in the opposite direction, the sperm bots are applied. Now, so when we're talking about cargo delivery, so another question arises is that multiple cargo delivery to a target site. So sperm bots have the ability to form a sperm train because of the presence of an iron coating at an angle of 75 degrees on the head of the sperm bots. So when they form, once they form the chain, they are capable of delivering the cargo, which in this case is heparin, to the target site in multiple amounts. But the only point of concern is that once a sperm bot chain is formed, its speed decreases with comparison to a normal sperm bot. So when we're talking about introducing sperm bots in the blood, we need to talk about the effect of blood velocity on the sperm bots. So as is evident from the picture and was obtained from the experiment, that with increasing blood velocity, the speed of the sperm bots gradually decrease. However, because of its ability to anchor, it regains its speed after a certain point of time. But this part needs to be looked into in future. I'll be talking about three experimental setups, that is setup A, B, and C. In the first one, sample blood with normal sperms were introduced. In the second one, sample blood with SHC sperm bots without the heparin liposome complex was introduced. And in the third one, sample blood with SHC sperm bot with heparin liposome complex was introduced. Prior to that, the activated clotting time of normal sample blood was noted, which was around 85 plus minus 18 seconds. In first two setups, it was observed that it was observed that there was a particular activated clotting time. However, in the third setup where heparin was present, no clotting was observed, from which we could conclude that heparin was successfully developed at the clotting site by the sperm bots. So since the entire experiment was successful in removing the clot, we hope that this apparatus and this practice can be utilized in future for treating other human illness and can prove as a successful nanobionic approach. To conclude today's presentation, one thing is that in order to employ the ideas in the practical world, both applications need to be worked upon a little bit. With respect to the light emitting plants, intensity and duration of light can be increased by better integration of nanoparticles and by avoiding ATP limitation. With respect to sperm micromotors, certain additional optimizations like maintaining an optimum speed of the sperm bots at greater blood velocities and testing their performances in larger blood vessels might be required. So these are the references from which we gathered our information, and thank you.
A very interesting talk.
Thank you, ma'am.
Well, in the medical field, we are of, I mean, improvisements and newer technologies coming and present there. But I basically liked the light emitting plants a lot. So basically, new technology, nothing much as a question I should ask. It was a good presentation.
Thank you.
Yes, I also liked it very much. And I just wanted to ask that the light emitted using this luciferin pathway
Yes,
is
ma'am.
known as cold light emission. Why is it so? Can you tell? How can
I'm
it be
sorry.
different?
I could not get your words.
It is a type of cold light emission. So why it is termed so? How can you differentiate it from the light emitted in phosphorescence or fluorescence? What is the advantage here? Why it is called cold light emission? Just apply your
Ma'am,
common sense.
it can be called the cold light emission because in this case, the enzymes used do not give anything else other than light as a byproduct, which I would guess is why it's called cold light emission. I'm sorry, I actually do not have much idea about it, but as the term suggests, I think other than light, we are not getting any exothermic reactions.
Yes,
So
that is the
that could
thing.
be.
Not much energy is lost as heat energy in this case.
Okay, ma'am.
Okay.
Thank you, ma'am, for letting us know that.
Thank you.
So, ma'am, I'll stop the screen share.
Yes, yes,
Okay, ma'am. Thank you, ma'am.
Thank you, ma'am.
yes.
Thank you, Moitri Sharkar and Tanisha Biswas. The last PG presenters are Mengla Talukdar and Asmita Sinha.
Yes. A very good evening to everyone. As the world is struggling to find new therapeutics for the recent coronavirus, we have looked into a new angle of dealing with this problem. That is by using small protein scaffolds. But what are these scaffolds? Have they been used for any therapeutic reasons earlier? To answer such questions today, Ashmita and I are all set to talk about anticalin proteins as therapeutic agents in human diseases. Next slide. Okay. Anticalins are artificial binding proteins that are derived from lipocalins, and lipocalins, as we all know, are robust proteins that have pathological aspects to it, which provides medical applications. Now, we have understood that their typical structure is a four-loop hypervariant structure along with a beta-barrel backbone, which makes a cup-like structure together. This allows anticalins to bind with a diversified range of amino acids by keeping the integrity of the lipocalin structure. Next slide. Yes. Today we'll be dealing with three therapeutic applications, that is as antidotes, antagonistic, and as tissue targeting vehicles. Next slide. The first technological application is the exploitation of anticalin technology for asthma treatment. Due to industrial revolutionization, there has been increased incidences of allergic asthma. Allergic asthma happens due to activated T helper cells that mediate lung inflammation by releasing cytokines such as interleukin 4, 5, and 13. 4 and 13 play an important mediatory role and hence provide a good ground for medical interventions such as reduction or blocking of IL-4 action. Anticalin here does that. They target the receptors of IL-4 and they help in the reduction of the pathogenesis of any allergies such as asthma. Next slide. Attempts has been made to block the IL-4R alpha, where by fast display technology, the lipocalins are separated from humans, and then they are produced in E. coli cells, where they are observed by SPR and flow cytometry techniques. The physiochemical properties were also examined to characterize their drug-like properties. The results have shown that they act as competitive antagonists and with high affinity. Next slide. Okay, so now coming to the practical application, there has been drugs that are under clinical trials, and one such drug is PRS-060. It has been said that they are inhalation drugs that directly reaches the lung because of their small, robust structures and an extended half-life. Interestingly, AstraZeneca has also been in the whole scene, and where they have agreed to collaborate with them and fund the further phase trials. Next slide. The phase 1 trial results have been out, and it was seen that the PRS-060 have similar potency to a hypersensitivity drug that is already in the market. Thank you. Now Ashmita will continue.
Okay, so now I am going to discuss about the antidote property of the anticalin molecules used in the treatment of metabolic diseases. Dyslipidemia is actually a metabolic disease which is caused due to high levels of low-density lipoprotein in the blood, which causes several cardiovascular diseases, including the atherosclerosis. Now, the low-density lipoprotein receptors present on the surface of hepatocytes and several other cells throughout the body bind to these low-density lipoproteins and then internalize them. But the proprotein convertase subtyrosine casein type 9, that is PCSK9, bind to these low-density lipoprotein receptors and induce their degradation. Thus, the molecules that inhibit the action of PCSK9 can be used to reduce the low-density lipoprotein levels in the plasma and can be used as a promising therapeutic study for the treatment of dyslipidemia. Now, the conventional antibodies available in the market for the treatment of dyslipidemia have usually a complex structure and a large size, followed by high cost of production and relatively high administration drug dose volume. Whereas compared to anticholine molecules, they have shown very promising results in treatment of dyslipidemia owing to their small size and low cost of production in a microbial expression system, as well as high solubility, which makes the treatment of dyslipidemia more convenient by applying a high drug dose concentration in a low injection volume. But the most important disadvantage with these anticholine molecules is that the naked anticholine molecules have a very short plasma half-life, and due to this, they are not retained in the blood for a longer period of time. But this can be circumvented by fusion of certain proteins to the anticholine molecules. As we can see in the figure A, that a albumin binding domain fusion protein is bound to the anticholine molecule at the C-terminal end via 3 glycine residues. This forms the anticholine protein named as the DS9001A. From pharmacokinetic analytic studies carried out, it was concluded that the plasma half-life of the naked anticholine molecules are much shorter as compared to the fused anticholine molecules. Now, I would like to discuss the antagonistic property of the anticholine molecules. The hepcidin, which is actually a hepatic bactericidal protein, plays a major role in the regulation of iron metabolism, especially in case of patients suffering from functional iron deficiency, which is a major cause of anemia. Now, this hepcidin actually binds to, as we can see in the figure itself, that the hepcidin actually binds to the ferroprotein. Now, the ferroprotein is the only iron exporter present in the surface of the macrophages, hepatocytes, and several other cells. And the hepcidin induces the degradation of the ferroprotein, thereby inhibiting the iron flow into the plasma as well as the availability of the iron for the erythropoiesis. Now, this can be treated by routine use of erythropoietin stimulating agents and high dose intravenous iron supplementation. But this can pose several critical threats. So, for the treatment of anemia, we can use antagonistic property of the anticholine molecules. This is the PRS-080, which is an anticholine molecule that is targeted towards hepcidin and helps in increasing the iron availability for erythropoiesis, as well as avoids the overload of exogenous iron. Now, in this case also, the half-life of the PRS-080 is enhanced by fusion with a PEG polymer of 30 kilodalton molecule. So now I would like to conclude our presentation. Anticholine technology offers a mature tool set for generation of modified human lipocalins specified for targets of interest, ranging from small molecules to peptides and even to proteins. Moreover, the affinities of the resulting anticholine molecules are much comparable and sometimes even better than the antibody technologies, especially in case of low molecular weight ligands. And apart from these, anticholine proteins also infer, as I already mentioned, solubility and high folding stability, which makes them to be administered in high drug dose concentration, but in a low volume. Crucial advantage of the anticholine proteins in medical application is that their low immunogenic potential. Now, since they are derived from the natural lipocalins, they can be derived from the natural lipocalins and deviate from their natural counterparts from a limited number of amino acids. So they generally do not evoke much immunological responses. As already explained, that the anticholine molecules are used extensively in the treatment of respiratory diseases, and their plasma half-life is enhanced by fusion of certain proteins. Now, finally, I would conclude that the anticholine molecules have shown promising results in preclinical as well as early clinical developmental stages of several therapeutic cases compared to standard of care therapies, including the antibody technologies, hence proving anticholine as a novel class of protein drugs that may even complement or surpass the conventional antibodies in many areas. Okay, so now thank you. These are the references that we have used. Thank you.
Okay, so Ashmita, you were speaking on anticalin, and you dealt upon basically their advantages over the antibodies therapy. Okay, or the antibody therapies
Yes, ma'am.
or technology. So, can you give me or cite a specific example wherein instead of using the antibody technology, this particular anticalin has been used, and it has definitely resulted better. Common example of such kind of a treatment.
Ma'am, in this case only that in this case, for the use of anticalin molecules are we have seen that use of anticalin molecules have shown better results instead of antibodies, and in the clinical first phase clinical stages also they have shown better results. And as they do not usually evoke any immunological response, so the results of the first phase was quite successful, and this has and from that they have inspired to go in the next level of treatment.
Okay, so it's already in trials, right?
Yes, yes, ma'am.
Okay. Okay. Thank you.
Okay, thank
Thank
you.
you, ma'am.
No question from my part as such. Thank you.
Thank you, ma'am.
Okay.
Thank you, ma'am. So, ma'am, we can stop sharing.
Yes,
Yes,
you
yes.
can sharing.
Thank you, Meena Talukdar and Oshmita Sinha. On completion of the presentations by the PG pupils, we now move on to the mini presentations. Bikram Dhara and Nibanjan Sengupta, research scholars of the Department of Microbiology, will judge this event. The rules are first 5 minutes are provided to the speakers to talk, and then 2 minutes is for question answers. The first speakers here are Dibbu Mojumdar and Samriddhi Golder.
Are the slides visible?
Yeah, continue.
Okay. Okay. Good evening to one and all present here. Today, Samriddhi Golder and me, myself, Dibbo Mojumdar from the UG Department of Microbiology, will be presenting catalyst in the rapid inactivation of the causative agent of COVID-19. SARS-CoV-2, the causative agent of COVID-19, created a menace since it had emerged in Wuhan, China in December 2019. The mild symptoms of COVID-19 include dry cough, fever, upper respiratory infection, and to severe extent, pneumonia-like disease and multi-organ disease. The viral particles spread through droplets, aerosol, and droplet nuclei. The aerosol remains suspended in the air for a long time, while the droplets contaminate the inert surfaces. Several COVID-19 cases were found in the indoor environment. Therefore, a study was carried out to make use of photocatalysis to reduce the viral infection in the indoor environment. Now, Samriddhi will elaborate the role of the photocatalysis in this experiment.
Okay, now let's have a look at the mechanism behind this process. In this experiment, tungsten trioxide has been used as the photocatalysis, and normal or artificial light in visible spectra has been used as the photon source. Now, WO3 get excited upon the exposure to the visible spectra and converting the energy to electron and electron gaps. And WO3 reacts with the surrounding air moisturizer and oxygen to release hydroxyl and superoxide ion. This reactive oxygen system intermediates the damage of damage the membrane of bacterial cells and other cells and tissues. This technique is used to damage bacterial and viral cells, organic and inorganic compounds, pollutants, polymers, and volatile organic compounds. Now, let's have a look at the method of this experiment. The system in this liquid phase comprised of two components: a metallic mesh filter with WO3 coating on it and an antiviral cotton fabric soaked in a metallic nanocluster based on a copper solution. Now the viral stock solution was diluted to 1:100 and 80 ml of the solution was obtained. Now the infectious titer was about 17,000 PFU per ml and it was introduced into the photocatalytic device from the top and liquids were collected from the bottom in every 10 minutes for 16 minutes time period. Now the samples were taken for viral plaque assay in Vero cells for and further analysis of the viral RNA load using the real-time qPCR. Now this will be explained by Dibbo.
And an overview of the viral assay. The Vero cells were seeded in the wells in the Eagle minimum essential medium, which was enriched with fetal calf serum. After the culture preparation, serially diluted viral samples were incubated with the Vero cells. The cell supernatant were removed, followed by the addition of methyl cellulose. After 3 days, cell fixation with formaldehyde or PBS solution, followed by staining with crystal violet in methanol was done. At the end of the assay, the viral plaques were observed under a stereoscopic microscope. Let us know about the real-time qPCR assay of this experiment. The viral samples were collected at different time intervals, and the viral RNA was extracted from the samples by the viral RNA mini kit. The presence of the viral RNA copies were detected by the real-time quantitative PCR method for the nucleocapsid gene. The viral RNA content was quantified with a COVID-19 kit, and all the data were statistically analyzed. The results of the experiment. The kinetics curve showed that the device, after 10 minutes, was able to reduce the viral infectious titer by 98.2%, which increased to 100% inactivation after 30 minutes. The viral RNA content was evaluated, and it was found that it was 1,000 times greater than the viral infectious titer obtained in PFU per ml. Now, Shamriddhi will convey the final message.
Next slide. Okay. Now let's come to the discussion and conclusion. The use of tungsten trioxide is advantageous because it does not require any UV light and all the photocatalytic reactions takes place within the device without releasing of any substances, thus it reducing the threats towards human and animal health. The system requires minimum maintenance and consume less electricity. The test can be done within air treatment device with the same filtering system. So through this presentation, we wanted to convey that the tungsten trioxide-based photocatalysis has the potentiality to minimize SARS-CoV-2 content in the air and prevent the contamination of inert surface in indoor. Thank you.
Hello, am I audible? Hello.
Yes.
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 Thank you for your presentation. And my question is, you are basically talking about an air filter, right? An air filter which filters
No, it
viral
can also
particles.
be performed in liquid phase also. Means the experiment was performed in the liquid phase, and it can also be used in a air in a air treatment field device also.
Okay, is there any valid data on aerial system, like they have used it
No, actually,
in
the
some
study was done using a liquid phase, and the study means conclude that it can be done in a air treatment device.
That's okay, but how can you confirm from that system that it will work in aerial system also, like that,
Because
with same efficacy?
means the air humidity which is present, the photocatalyst, it will also work due to the photocatalyst will also in the presence of the air moisture and the oxygen present, so it will also the photocatalysis reaction will also take place.
Okay. Is there any air suction pump in this machinery?
No, actually
No,
it
no,
was
no.
done in the
Hello. Yes.
So it was actually the study was done in a liquid phase, so the it does not give an the overview of the aerial device. So so maybe actually the samples were being used from the top, and and it was being collected from the bottom. So I don't think there will be a suction pump kind of.
Okay, but in case of air purification, this can't be done. So, what is your insight about that?
Actually, this is just a preliminary just experiment done by the researchers, and actually it was done in the liquid phase. So the experiment should also be done with the air treatment devices, so as to get an idea that whether it can be done successfully with the air treatment device also.
Okay, thank you. No more questions.
Thank you.
Debanjanadi, would you like to ask any questions? Hello? Hello?
Hello, can you hear me? Hello?
Yes, yes, yes.
What is the outcome of the experiment?
The outcome of the experiment is that the photocatalysis, which is a physical technique, means we can in the indoor environment while the people are working in different kind of work, they are involved. So if this device is implanted in an indoor environment and by performing this reaction, the viral load or the viral content present in the indoor environment, it can be reduced. So, and also one benefit is that this system functions under visible light, so we don't require any UV light. So it is also advantageous because the people will also can work in the indoor environment, and the device can also function and reduce the viral content in the indoor environment.
Thank you.
Thank you.
Okay. So can we stop the presentation?
Sure.
Okay, thank you.
Yes.
Thank you, Deepu and Shamriti. The next presenters are Niti Chaudhuri and Srijit Shah.
Is this slide
Good
visible?
evening, ladies and gentlemen.
Yes, you can continue.
Thank you. Good evening, ladies and gentlemen, my respected judges and my dear viewers. I, Niti Chaudhuri from BSc Second Year Department of Microbiology from the St. Xavier's College, and my partner,
Srijit Shah, St. Xavier's College Autonomous, second year, Department of Microbiology.
will be presenting to you a mini presentation on the topic polymer-based nanoadjuvants for the hepatitis C vaccine. So to understand this topic, let's start from the very basics. So what are vaccines and what are the disadvantages?
Excuse me. Hello?
Yes.
Can you check your microphone?
Is it not audible?
Voice is not clear.
Hello? Hello?
Continue.
Okay, so should I start again, sir?
No, continue.
Okay, so the first vaccine, which was discovered in the year 1976 by Edward Jenner, they are substances which contains a live attenuated version of the microorganism which causes the particular disease in question. Even though effective, they were very reactogenic, and due to this, safer, less reactogenic vaccines were developed. However, this was achieved with a compromised vaccine efficiency, and to solve this, we had adjuvants. So what were adjuvants? Adjuvants are defined as substances used in combination with a specific antigen that produce a more robust immune response than the antigen alone, thus encompassing a wide range of materials. Next, we have the steps in function. So the sustained release of silver along with the adjuvants from the injection site allows the increase in the contact period of silver with the macrophage or other silver receptive cells. This is called the depot effect of the adjuvants. Step 2, the introduction of these substances causes the release of the cytokinins, which in turn stimulates the immune system of the body, which causes the release of the helper T cells 1 and 2. The three widely known examples are shown on the screen. Next, I shall define what is a nanoparticle. So at present, nanoparticle development focuses on especially the biodegradable and the biocompatible nanopolymers that are used as a delivery systems to trigger both the humoral and the cellular immune responses. These are potent immunodilators that control the release of antigens, thus providing a better quality of immune response. These are called nanoadjuvants. So the different advantages are shown on the screen alongside. Next, moving on to what is a PLGA. So the nanoparticles act as vaccine and antigen delivery vehicles by encapsulating the antigen, and then these surfaces have the ability to recognize the target cells and also permits the gradual degradation of the polymer of the particle within the cell. This allows for the effective antigen activity. Now, my partner shall proceed to the advantages of PLGA and how they can be incorporated in the HCV vaccine. Over to you, Srijit.
Thanks, Neeti. PLGA, which stands for polylactic co-glycolic acid, has been gaining a lot of popularity in this field of vaccinology and nanotechnology. This is mainly because of its two properties, that is, it's a biodegradable polymer along with a very gradual degradation rate. PLGA, which stands, the efficacy of these PLGA particles has been confirmed by the American Food and Drug Administration and has approved PLGA for human use. Now, coming to our next question, what is the hepatitis C virus? Now, the hepatitis C virus is the envelope virus, which has a single-stranded RNA as a genome. It consists of both the envelope and the core proteins, and it belongs to the Flaviviridae family of the viruses. Even though the exact procedure for the treatment of this virus remains unknown, it has been seen that the use of pegylated interferon and ribavirin was able to suppress the replication of this virus. Ribavirin is a nucleoside analog and an active guanosine which could inhibit the viral structure assembly of this particular virus. Now, there are many factors which contribute to the difficulties of producing an HCV vaccine as shown on the screen, but the main ones include a high genetic diversity between the genotypes and the escape strategies which were formed after evolution. This caused the research behind the adjuvants to begin, and the nanoparticle-based adjuvants gained popularity. Now, the relationship between the PLGA nanoparticles and the HCV was shown by a group of scientists, that is Rupnam et al. They observed that the HCV1B-E2 protein was encapsulated effectively in this PLGA nanoparticles. Therefore, they used this HCV1B-E2 PLGA system as a delivery vehicle to improve the efficacy of this antigen. Now, the research work on these nanoparticle-based drug delivery systems mainly include three main factors. That is the modification of the surface of these nanoparticles in order to improve the target characteristics, the detection of the carrier materials in order to get the suitable drug release speeds, and also optimizing the preparations of these nanoparticles with the help of targeted tissues, organs, and the blood. And yes, recently there has been a major breakthrough in this related to this virus. 3 scientists were awarded the Nobel Prize for the discovery of this HCV virus. These are the references. Thank you.
Thank you, Neeti and Srijit, for your presentation. I have one small question. Like you have said that the nanoparticle is biodegradable, right? What kind of nanoparticle you are using in this process? Because there are a few nanoparticles which are not that biodegradable, but they're being poisonous for animal system also. So what kind of nanoparticle you are using?
Sir, since this is mainly related to PLGA, the scientists have performed the study on PLGA, because PLGA itself is biodegradable in nature, and it can, therefore that's the main reason it's so famous in this field of nanotechnology and vaccinology.
And the core of the nanoparticle is made up of PLGA, right?
Yes, sir. That's the main brain. What you would say the brains of this entire system.
Okay. Next question is, you have said that they're triggering the cytokine release, right? Cytokine release from cells, right? Immune cells, right? So if they're inducing any specific kind of cells for the production of cytokine or for the release of cytokine?
So depending on the depending on the adjuvant, it can stimulate both the immune response, the cell-mediated immunity or the humoral immunity. If it's the cell-mediated immunity, it's mainly targeting the natural killer cells and the cytotoxic T cells.
Okay. Okay. Thank you. And the last question is it applicable only against the flavivirus?
So this is a very recent paper of 2020. So currently it's been implemented for flavivirus and HCV, mainly because of the fact, as it was mentioned, that HCV has a very high genetic diversity, like 30% between its 7 genotypes. Therefore, it was first implemented here, and indeed, adjuvants can be used for many different against many different infections or microorganisms.
Thank you. Devanjanati, over to you. Hello. Devanjanati, can you hear me? Hello. Hello. Okay, please carry on.
So I stop sharing?
Yeah, sure.
It's not mandatory that you have to, both of you have to ask question. One or two questions asked, but matter ends there. Already we are running late.
Okay, sir.
Okay, thank you.
Thank you. Go
Thank
ahead.
you, sir. Thank you, sir.
Thank you, Neeti and Srijit. The next presenters are Bonlar Dashgupta and Mohima Shaha.
Mollar, are you there?
Yes, sir, is my slide visible?
Yes, yes.
Yes, yes, carry on.
So we start our presentation with the logo of medical sciences, which consists of two snakes intertwined between each other, symbolizing the worth mentioning effect of snake venom as an antimicrobial and healing agent, according to Greek mythology. Quoting the words of eminent poet Oscar Wilde, when it rains, look for rainbow. When it's dark, look for stars. I wish a very good evening to everyone present here. We heartily welcome you all to the second day of Modern Trends in Microbiology, Chapter 17. Today, myself, Molla Dashgupta, and my fellow presenter, Mohima Shaha, will be discussing on the topic of snake venom peptide, an emerging warrior against biofilm-forming skin bacterium Staphylococcus epidermidis.
With the development of science and technology, mankind have always tried to discover something new, especially to create something fruitful out of potentially dangerous things and use them for the benefit of civilization. Keeping this in mind, we will be presenting to you a promising reward obtained from snake venom, which is used as a modern day therapeutic. It is specially used to counteract the growth of biofilm-forming skin bacterium Staphylococcus epidermidis. We will discuss its effectiveness, its mechanism of action, and the reasons for selecting this particular peptide in antimicrobial use. Now, my fellow presenter Mollar will throw some light upon how the experiment was carried out. Over to you, Mollar.
Thank you, Mohima. So as we know, the increase in bacterial resistance phenotype poses a worldwide threat. Hence, new and effective strategies must be created. One such major problem, which is most prevalent nowadays, is the biofilm formation. 75% of human microbial infections occur via biofilm formation, since firstly, its unique, well-organized form provides barrier against action of any non-antibiotics, and secondly, it is able to accumulate equally well on both abiotic and biotic surfaces inside human body. Around 80,000 cases of blood infections are reported in USA every year, and 17 to 39% of prostatic endocarditis is caused by it. In this study, we present a 11 amino acid long peptide named pseudonazide, which has antibiofilm activity against Staphylococcus epidermidis. This peptide belongs to a class of peptide called CRAMP, cathelicidin related antimicrobial peptides,
which is a group of peptides known to be used in antimicrobial drug treatment. As the first part of the experiment, around 170 MPs were collected from venom obtained from ants, spiders, snakes, etc. and sequence alignments for each taxonomic group was performed using cluster X, which finally revealed 17 conserved motifs. After shortlisting 17 conserved motifs, having different charges and hydrophobicity, antibiofilm testing was done using crystal violet stain, which revealed that the second peptide, later named as pseudonazide, is most effective at 0.025 millimolar concentration in inhibiting the growth of bacteria by 63%.
Fluorescent microscopic technique using FITC revealed that the pseudonazide is interacting with a site on bacterial cell envelope and not on the biofilm matrix. Since the number of cell death has increased and the number of impermeable cells has decreased. This reveals that pseudonazide definitely have changed the structural integrity of the cell membrane, thereby interfering in permeability of the cell membrane.
As the third and last part of the experiment, the expression of certain genes which were coding for lipotecoic acid increased significantly, like glycosylated transferase, flipase, LTA acid synthetase, etc. This lipotecoic acid is a negatively charged polyglycerophosphate chains, which must have interacted with the positive charges of the basic amino acid residues of the peptide, causing strong interaction, finally cell lysis and death. The expression of LTA genes with pseudonazide can be explained by the following graph.
Finally, using 7 different cell lines, hepatocellular, colorectal, lung, breast, prostatic, etc., no decrease in live cell count was found at 0.025 millimolar concentration and 24 hours of incubation. This indicates that pseudonazide is not at all cytotoxic to human beings, rather effective in its cause. Also, as it is a 11 amino acid long peptide, the industrial preparation of it must also be easier. Now, last but not the least, these studies can further open new research field for discussing about the huge importance of venom in therapeutic use.
These were the few sites from which we referred to. So that's all. Thank you.
Thank you.
Thank you, Mohima and Molnar. Very nice presentation.
Thank you, sir.
Thank you, sir.
One small thing that the snake, the scientific name of the snake, that spelling was wrong in your slide. Okay.
So it was the scientific name is Pseudonaja textilis.
E was missing there, right? My next question is any like application of this pseudonazide from from commercial point of view. Have you thought anything from commercial point of view, like how it can be commercialized or?
Sir, first of all, as Mohima said that it can be manufactured very easily since it is just a 11 amino acid long peptide. So it will take less time to prepare, and it will also be very cost effective, and it can be used in the field of therapeutics as required. So.
Okay. We are getting pseudonazide from snake venom, right?
Yes, sir.
What kind of snake venom it is? There are several types of snake venoms. We are getting this compound from a specific type of snake, and that must be a specific type of snake venom. What it is?
So, do you mean whether it is harmful for us or not?
No. Which kind of snake venom it is? There are several types of snake venoms like myotoxins, neurotoxins, or cytotoxins and neurotoxins. So what kind of snake venom?
Okay. So this is most probably cytotoxin in nature, but if it is used in less amount, in controlled amount, it is found to have no effect.
As this snake is an elapid, so the venom is of neurotoxic type, right? The venom is
Okay,
of
sir. Okay, sir.
okay.
Sir,
Thank you
that
so
was
much.
something we missed out.
Thank you so
Okay,
much.
sir. Thank you, sir. Thank you, sir.
I have a
Thank you
question.
so much, sir.
Hello.
Thank you so much, sir. Thank you.
Hello.
So, yes, ma'am.
Hello. I have a question. What is
Yes,
the exact
sure.
molecular weight of this nucleoside?
Uh, the
What is the
molecule,
exact molecular weight?
ma'am, as far as I remember, it's four 400 to 500 atoms, but not sure about that. It's
Okay.
it's 400 to 500 daltons, but I think so. And it is quite small. It is not so huge.
Yes, it is 11 amino acid long, right?
Yes, ma'am. 11 amino acid long peptide.
Thank you.
Thank you.
Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you. So, should I stop presenting?
Yes, yes, sure.
Okay, sir. Okay.
Next presentation.
Thank you, Mohima, and Mollar. The last presenters are Sweta Mahanta and Shuchishmita Shikdar.
Is my screen visible?
Yes, yes. Carry on. Carry on. Yes.
I don't know why video is not turning on. Okay. My video is not turning on. I don't know why. So, good evening, everyone present here. So today our topic for presentation is antimicrobial peptides against drugs-resistant bacteria. Me, Sujishmita Shikdar, and my co-mate Sweta Mahanta are going to present this. So we all know about the drug-resistant term. So why you have asked why we have chosen this topic? This is because 70% of pathogenic bacteria are resistant to at least one type of antibiotic. So this is the main drawback of any resistant, which uh, which treatment efficiency of the patient, leading to multi-drug resistance. So what do you mean by the term the bacteria gets resistant? So bacteria either reduces or eliminates the effectiveness of the drug or the agents. These mechanisms can be possible because interaction with the bacterial species and the host. The bacteria may produce protease or change their cell surface and many other actions. All these actions are done by the bacteria to survive in the changed environment. So here comes the main attraction of today's topic, that is antimicrobial peptide. So antimicrobial peptides we know as used as potential therapeutic application because of the following reasons. Antimicrobial peptides are generally naturally or synthetically produced anti-infectives that has a major role in microbial ecology and also contribute in our innate immune system. They are very small in size and largely cationic in nature because of the presence of large arginine and lysine residues in the amino acids backbone. They have also have secondary structures, alpha helical, beta stranded, beta sulf hairpin loop, and extended chains. This cationic nature of the antimicrobial peptides helps them to interact with the negatively charged microbial membrane. They are amphipathic in nature, which helps them to interfere with the DNA or the protein synthesis. They are not only a drug effective on bacteria, they are also effective in virus, fungus,
tumor forming, that is anti-cancerous or biofilm formation. So here comes the mechanism. First, it targets the bilayer disruption, that is, disrupt the microbial membrane, further internalization of the process. The membrane disruption is called the disruptive process. It may be done by the three main reasons, that is toidal pore formation, carpet formation, and metastatic formation. This differs from species to species, that it is differed for gram-positive and gram-negative bacteria. They also have immunomodulatory actions which encourage the cells to produce more chemokines, stimulate clearance of the infection, and induce acceleration of the healing, which result in influence of programmed cell death in multicellular organisms. Next, Sweta.
So the main disadvantage of these peptides is their poor proteolytic stability. Hence, multimeric peptides were designed keeping the main model of the AMP and their physicochemical and membrane activity related properties same. These multimeric peptides are termed as dendrons or dendromers, which are semisynthetic in nature. Their extensive branching gives rise to steric hindrance that limits the cleavage rate of the plasma peptides, thus improving their pharmacokinetic properties. So here are some of the examples of the dendrimers where divalent lysine is kept as the inner core and modifications are made around it either by addition of more lysine residues or by the addition of other residues such as arginine, leucine and tyrosine. Now we are focusing mainly on this fourth type here, which is the dendromer named SB056. Next slide please. So in SB056, as you can see, two peptide branches are attached to the main lysine residue, which is the linker, having an 8 amino octamide tail bound with C terminus. The N terminal end is represented by a white box in by a white plus in a blue box. The hydrophobic residues are given in yellow, and the hydrophilic residues are given in blue. So the upper figure represents the initial configuration of the SB056, and the first two residues marked with red borders were later interchanged to produce a beta SB056, which is perfectly amphipathic in nature. So change the slide please. So the effectivity of this rearrangement can be seen in this experiment where two synthetic lipid bilayers POPG and POPC are taken that mimics the bacterial membrane. Now POPG is anionic while POPC is zwitterionic in nature. And we can see that beta SB056 binds in an asynchronized manner, the asynchronous beta stranded configuration to the membranes, while beta SB056 gets self-assembled in an orderly manner. Therefore, this figure basically shows that with the increasing anionic concentration in the membrane, the peptide binding capacity gets increased, which eventually causes disruption. Now, change the slide. Hello, Sujishmita.
I have already done.
But I can't see it. Yeah. So this is the experimental evidence which shows that without beta SB056, that is in the control, both mucoid and non-mucoid strains of Pseudomonas aeruginosa show uninterrupted growth. But in the presence of the peptide, as seen in the test case, the colony forming units is reduced by 3 log cycle within 5 minutes of incubation. So going to the future prospects, change the slide please.
I have already done it.
Yeah, so going to the future prospects, there are many such prospects, but we have selected few, such as these dendrimers can be used for the versatile clinically applicable agent synthesis, such as those that can be used in the cancer therapies. Then selection pressure driven resistance can be restricted by these peptides by developing targets for hosts rather than for the microbes, and delivery systems can be developed for the sustained release of AMP in the body. Now, these are the reference of the papers which we have used for our presentation, and
with this, we come to the end. Thank you.
Thank you.
Thank you, Shuchishmita and Sweta, for your nice presentation. One question, that is, you were talking about dendimer SB056, right?
Yes.
Is there any report of human trials yet?
Yes, it has been used in vivo and for the Pseudomonas aeruginosa, which causes biofilm in the lung epidermal cells, and it is seen that uh, this this peptide plus the chelating agent EDTA can cause 99.9% reduction in the biofilm. But there is a drawback, that is, it causes less than 22% cell death as well. So, as far as recent reports say, when this peptide has been given to the cell line A549 along with the LPS stimulation, this it showed that the cell death was decreased to less than 5%. So, that is a positive aspect, and further trials are going on in this topic.
And is it active against any specific kind of cancer lines, cancer cell lines?
Um, the reports say that it has been tried against tumors, but it's still under trial. Like we haven't got any specific result as such.
Okay, thank you so much.
Thank you.
Should I stop sharing?
Yes, sure.
Thank you, Shweta and Tutishmita. With this, we come to an end of the technical session. I request the spectators to keep an eye on the chat box as a feedback form link can arrive at any time. We
I
begin the
have
next
something to
engineering.
announce.
Yes, sir.
Yeah, actually, I would request the two scholars. First of all, thank you, Bikram and Devanjana. I would request you to, this is a session combining both BSc and MSc, right? If I am not wrong.
Yes, sir.
So you have to mark first position, second position, and third position, right? Ankita, this is what we want.
Yes, sir.
Yes, sir.
So please mark the first, second, and third teams with their names and WhatsApp it to me.
Okay, sir.
Now, I have some general observation. I really appreciate the way you people have prepared yourself. It's not a matter of joke, because first of all, classes are in full bloom. The classes are going on, and at the same time, you are preparing away from each other. So you prepared in your home, and the other person has prepared from his or her home. But again, this coordination you could maintain, and that's really creditable. But one important thing is that you people, particularly when I saw it from some MSc students, why you are using so much write-up in the slides. You see, write-up should be minimum. There should be some illustration and explanation. You don't read through the slides. This is the last thing you should do. And if you do that, then naturally it goes against you. So this is just a beginning. Modern Trends is just a training session. You have to go a long way. If you are in academics, you will have to present many things. You have to learn also. It is not only the fact that you will be presenting academic, poster academic talk. You can also present in, say, any interview also. You might be asked to prepare a presentation and present it to your company. So these things you should learn. You speak more and you write less. And if you write, that also should follow certain pattern. So today was a very big session. It started with an illuminating talk by Dr. Nandini Haldar, followed by, I think, 6 presentation from undergraduate and 6 presentation from postgraduate and 6 presentation from 6 title from Both
Yes,
these
sir. Yes, sir.
7. Okay, fine. So tomorrow again there will be a big day. Tomorrow we will be having the morning session starting at 9. Then it will continue till 10:30. Then we have the afternoon session from 1 till 4 p.m., which is mostly the outside students. And also we have the guest speaker from US, Samadrita Bhattacharya, speaking in the evening from 6 o'clock onwards, right? And after that, there will be the valedictory and then the cultural slot. So we come to an end of MTIM chapter 17, day 2. And thanks one and all for your participation and for your enthusiasm. This is most important.
Thank you, sir, for giving us the opportunity.
Thank you, sir.
Okay. So অঙ্কিতা আর কিছু বলার আছে তো বলে শেষ করে দিচ্ছি এই সেশনটা।
Yes, I request the webmaster to stop the live session. We call it a day.